Hi, my name is Osama Naga. We'll start discussing the Pediatric Endocrinology chapter in the Pediatric Board Study Guide. Check the third edition for all updated information. The first part we'll discuss in this chapter is the growth, linear growth, length or height. Any child present with abnormalities in the linear growth, length or height, you should consider these factors affecting the normal linear growth. For example, genetics, growth hormone deficiency, gonadotropin problems, sex hormone problem, testosterone or estrogen, thyroid function or thyroid diseases, nutrition, psychosocial stress, occult organ dysfunction, for example, renal or GI diseases. Growth velocity is the most important tool in early detection of abnormal linear growth. For example, you can have a child crossing percentiles for height or length on the growth chart, and this will demand evaluation even if the height is still within normal range. So you can have abnormal growth velocity and still the height within normal range on your growth curve. Growth velocity is the child's height pattern. Abnormal growth velocity means crossing percentile lines on a linear growth curve even if the height or length is still within normal range. Accurate height measurement is usually performed at 6 months interval. So what is short? Short means shorter than 50th percentile or shorter than 2 standard deviation below the mean. Growth velocity according to the age. From birth to 1 year, this is the fastest time the infant will grow, is the first year of life. Is about 25 centimeters per year. And you may see crossing percentile towards the parent's genetic potential. For example, if you have a small infant born to tall parents, you may see upward crossing in the growth curve. And if you have a large infant born to short parents, you may see downward crossing on the growth curve. And this is usually accomplished by 9 to 12 months of life. And between 1 and 3 years, the growth rate starts to slow down. And between 1 and 2 years, you will see the linear growth rate is half of the first year, is about 12.5 centimeters per year. And between the second and third year, and the growth rate is about 8 centimeters per year. And this is what is well known as growth deceleration. Between 3 years and puberty, the growth rate will be steady and it will be about 5 to 6 centimeters per year. Adolescent or during adolescence, the growth rate starts to speed up again and it can go up to 15 centimeters per year approximately. And this is what is well known as growth spurt. When assessing any child with abnormal linear growth or concern about the linear growth, you need to assess the target height. For boys, father's height in centimeter plus mother's height in centimeter plus 13 divided by 2. For girls, father's height in centimeter minus 13 plus mother's height in centimeter divided by 2. Most of the children usually achieve an adult stature within approximately 10 centimeters of their target height. Diagnostic approach to the short child. Detailed medical history including prenatal, for example, intrauterine growth retardation or problems after birth. Physical examination including dysmorphic features or any abnormal facial features including syndromes. A calculation of upper to lower limb ratio to exclude disproportionate shortening, for example, skeletal dysplasia. Growth velocity, bone age and target height. We need all this information when approaching any child with a short stature. This is an excellent diagram for approaching any child with a short stature. If you have the height or length is affected more than the weight, or the height and length is less than the weight, this is a failure to grow. And if the weight is less than the length, or the weight is affected more than the length, this is a failure to thrive. So when approaching any child with length or height is affected more than the weight, this is a failure to grow. You need to determine the growth velocity, and we learned that in the previous slide. Growth velocity and bone age. So if you have normal growth velocity and the bone age more or less equal to the chronological age, it means no bone age delay, you are dealing with intrinsic shortness. For example, familial genetic short stature. In this case, you will see the predicted height very similar to or close to the mid-paternal height. If the predicted height is much less than the mid-paternal height, you should expect a Turner syndrome in this case. Also possible causes IOGR and spinal irradiation. If you are dealing with normal growth velocity and the bone age is delayed, or if you see the bone age is less than the chronological age or delayed bone age, this is delayed growth, and the best example of that is constitutional delay or mild chronic diseases. If the growth velocity is abnormal, like for example 6 years old with the growth velocity, for example 3 centimeter per year, and the bone age is delayed, you are dealing with attenuated growth. For example, endocrine disorder, and this is usually hormonal. Endocrine disorder, growth hormone deficiency, hypothyroidism, Cushing syndrome, hypogonadism. On the other hand, if you are dealing with a child, the weight is affected more than the height, this is a failure to thrive. So evaluate caloric intake, renal, bowel, and thyroid function. Example of that: inadequate caloric intake, malabsorption, for example cystic fibrosis, excess caloric needs, for example a child with cardiac disease. First condition you need to be familiar with any child present with abnormal linear growth is constitutional delay of growth and puberty. First thing, from the family history, you will find one of the parents is a late bloomer, or family history of growth and pubertal delay, one of the parents. Delayed bone age is very important. Linear growth is below but parallel to the lower percentile of the growth curve. If you do hormonal study, it will be normal. The child will attain or will reach the final adult height. And if the child has a stress or social stress in school, or worry too much about his height, low dose of testosterone therapy, or observation and reassurance. This is a classic growth curve for a child with constitutional delay of growth and puberty. So this child was born with a normal length, and the height start to decline at age of 4 and continue to be below and parallel to the lower percentile. During the growth spurt, most of the children in his class, they grow quickly, and usually they present during this time, and this child has delayed in the linear growth but finally will reach the final adult height. If you look at the weight here, is affected but after the height, not before. So this is a linear growth problem curve consistent with constitutional delay, and this is a child, if you do the bone age will be delayed. The next important linear growth abnormality is familial short stature. You will see here the height is below 5th percentile, the growth velocity that is parallel but below the normal growth curve. The bone age is approximately equal to the chronological age. The time of pubertal onset is normal, and the height percentile track that predicted by the paternal genetics. So the child will be short, similar to the parents. This is an example of genetic short stature. This child was doing okay at age of 2 years of age. Then from 3 to 4 start to cross percentiles, going down below the 5th percentile and parallel to the 5th percentile, so below and parallel, and reaching the predicted height for the mid-paternal height. And the bone age for this child is equal to the chronological age. And if you look at here also, the weight is affected after the height. The weight is affected after the height. So this is a classic example of a child with familial short stature. The next case, which is short and thin child. If you see initial decline in the weight gain followed by the decrease in growth velocity, this is a gastrointestinal or nutritional problem. So consider primary gastrointestinal disease, for example, malabsorption, nutritional, renal, or other chronic systemic diseases. For example, if you look at this growth curve, this is a classic growth curve for failure to thrive, or growth failure secondary to malabsorption. You will see here the height is declining after the weight. So you will see initial decline in the weight, and then the height will follow afterwards. So if you have the weight is affected first, then followed by the height, this is mainly gastrointestinal or nutritional or other systemic diseases. Short and dysmorphic features or disproportionate short stature. Any short girl with dysmorphic features, you should obtain karyotype. Genetic referral will be very helpful. Any short girl, you should consider Turner syndrome in your differential. Abnormal upper to lower limb ratio, this is a red flag for skeletal dysplasia or osteochondral dysplasia. A radiological survey will be very helpful if is read by experienced radiologist. And you have to keep in consideration there is up to 200 different cases or abnormalities in the bone growth and cartilage has been identified. The most common example and well known as achondroplasia, another example Larsen syndrome, and many other examples. So the best way to approach that, measuring the upper to lower limb ratio, and if it's abnormal you do a radiological survey, and this will help in the diagnosis. Approaching adolescent with deceleration in the linear growth, physical examination, if there is delayed sexual maturation and delayed bone age, you order gonadotropin level. If the gonadotropin level is elevated, this possible primary gonadal failure. If it's normal or low, this possible constitutional delay or gonadotropin deficiency. Short and obese is a red flag. Short and obese is a red flag. Normally children with obesity are tall, not short. So if you present with a case like that, a thyroid function test will be very helpful. If the TSH is elevated and the free T4 is low, this is hypothyroidism. Bone age is very important to determine the bone age if it's delayed, advanced, or similar to the chronological age. Determining the karyotype in a short girl. Any short girl is a Turner syndrome until otherwise is proved. You investigate for growth hormone deficiency by measuring the serum insulin growth like factor 1 and insulin like growth factor binding protein 3. And if they are deficient, you confirm with a stimulation test for growth hormone. And if the test confirm growth hormone deficiency, this is secondary to growth hormone deficiency. If all the investigation above are normal, the next step you order or you screen for Cushing syndrome by doing 24-hour urinary free cortisol with creatinine. And if it's positive, this is suggestive of Cushing syndrome. Cushing syndrome should be suspected in short and obese child, especially if they have hypertension. It is more rare than the above causes, but it should be considered in the differential. Associated conditions with growth hormone deficiency: Hall-Pollster syndrome, absence of pituitary gland, hypothalamic hamartoblastoma, post-axial polydactyly, means the extra digit on the radial side or the thumb side. Post-axial polydactyly or extra digits usually associated with congenital anomalies. Pre-axial usually benign. Anomalies of heart, lungs, and kidneys. Septo-optic dysplasia, absence of optic chiasm, optic nerve hypoplegia. Midfacial abnormalities like one single tooth in the middle, cleft lip, cleft palate, micropenis, microphallus. These conditions may be associated with growth hormone deficiency. Diagnosis of growth hormone deficiency: the height or length is more than 3 standard deviation below the mean. Slow growth velocity less than 5 cm per year. Delayed bone age. Low insulin growth or insulin-like growth factor, and low insulin-like growth factor binding protein 3. Provocative test or abnormal provocative test, usually done by giving the patients insulin, arginine, clonidine, or glucagon, and this should increase the growth hormone in normal children. Children with growth hormone deficiency, the test will fail to increase above 10 nanogram per ml. So the growth hormone level will be less than 10 in two different provocative tests with two different stimulants, with two different. This is usually diagnostic in most of the cases. Adverse effects of growth hormone: idiopathic intracranial hypertension or pseudotumor cerebri. The patients will present with a headache, blurring of vision, and high opening pressure when you do lumbar puncture, and the CT, of course, or the MRI will be negative. The slipped capital femoral epiphysis, gynecomastia, worsening scoliosis, and insulin resistance. This is a summary of different cases of short stature, constitutional delay of growth, and adolescence. In this case, the linear growth initially was normal, then it started to be below the lower percentile and parallel, but during growth spurt or adolescence, the height is more affected and more obvious, and this is the time where they present. and comparing to the children at their age in their class, their growth spurt is normal. But eventually these children, even without treatment, they reach their target height. There is a positive family history of delayed puberty or late bloomer. If you do bone age, will be delayed, and also their growth velocity is normal. Familial or genetic short stature, initially in this case the length or the height was normal, then start to be below the 50th percentile, but eventually they will reach their target height because one or both parents are short. Also, if you do bone age, the bone age here will be similar to the chronological age, will be no bone delay, no bone age delay, and the growth velocity in this case is normal. Primary nutritional deficiency or severe chronic illness, the weight here will be much more affected than the height. So if you see initially the weight is more affected than the height, this is nutritional or gastrointestinal or chronic diseases. Next one is congenital growth hormone deficiency. Initially in this case the length or height was normal, then it start to decline and the growth velocity here is below normal. Growth hormone deficiency was confirmed, then this child received growth hormone therapy and treatment, then the linear growth started to normalize. So again, the growth velocity here is subnormal or abnormal. If you do bone age, will be delayed in this case. Turner syndrome, this child start to show short stature, and the length here or the height start to be below the 5th percentile and continue to be below, and this child does not reach the target height. So here the height of this child is way below the target height. So if this is a girl, you should suspect Turner syndrome. Finally, I will summarize the most common 3 cases of short stature just to keep it clear in our mind how to make the difference. For the constitutional delay growth curve here, the growth velocity will be along or parallel to the lower percentile of the growth curve. For familial short stature, growth velocity is parallel but below the normal growth curve, below the 5th percentile. For growth hormone deficiency, the height or length is more than 3 standard deviation below the mean, means the growth velocity in this case will be abnormal. So here normal growth velocity, this is abnormal growth velocity. Family history, positive late bloomer or delayed puberty in the cases of constitutional delay. Familial short stature, you will have 1 or 2 parents are short, so will be a positive family history of short stature. For growth hormone will depend on the cause. For bone age, for constitutional delay the bone age will be delayed. For familial short stature, the bone age will be more or less equal to the chronological age, and in cases of growth hormone deficiency, bone age will be delayed. Hormonal study will be, most of the cases will be normal. Familial short stature hormonal study is normal. Here is abnormal. These children, they will have growth hormone deficiency. Craniopharyngioma. Craniopharyngioma is the most common pituitary tumor. The clinical presentation in this case is headache, visual disturbance, endocrine dysfunction. Diagnosis, you will do CT or MRI. Management is surgical removal. Neonatal hypoglycemia. The definition of neonatal hypoglycemia is the blood glucose less than 30 in the first 24 hours, then less than 45 milligram per deciliter thereafter in the newborn. Please correct that in the study guide. Is what was written by mistake 70, so the correction is 45 milligram per deciliter. The plasma glucose value below 50 in children is considered hypoglycemia. The causes or the most common cause is transient hypoglycemia because of prematurity or infant of diabetic mother, small for gestational age, perinatal stress, or sepsis. So remember, hypoglycemia can be a sign of sepsis in neonates. Other causes of neonatal hypoglycemia: inborn error of metabolism, for example acylcarnitine deficiency, glycogen storage diseases, gluconeogenesis disorder, fatty acid oxidation disorders, growth hormone deficiency, congenital hyperinsulinism. Genetic diseases, you need to memorize this syndrome, Beckwith-Wiedemann syndrome. They present with macroglossia, ear loop creases, visceromegaly, hemihypertrophy, and Wilms tumor. This can cause also hypoglycemia because of excessive insulin secretion during the neonatal period. So the initial presentation of this syndrome can be hypoglycemia, Beckwith-Wiedemann syndrome, macroglossia, earlobe creases, visceromegaly, hemihypertrophy, Wilms tumor, and of course hypoglycemia. The best way to diagnose rare causes of neonatal hypoglycemia, if the cause is not obvious, is to do critical sample and withdraw the lab during the hypoglycemic attack. And what you withdraw is glucose, bicarb, insulin, C-peptide, ammonia lactate, growth hormone, cortisol, free fatty acids, and serum ketones, acylcarnitine profile, urine ketones, urine organic acids, and you saved one tube for additional testing. This slide is to differentiate between rare causes of hypoglycemia, and you will use the lab result from the critical sample you obtained during the attack of hypoglycemia. I divided to the upper half and lower half. The upper half is without acidemia, and the lower half is causes of hypoglycemia with acidemia or with acidosis. So the first one is hyperinsulinism. Know that, very important to know that if you have hypoglycemia, the pancreas should not produce any insulin. So in this case, hyperinsulinism, the patient will not have any ketones or will be low ketones, low lactate. However, a high ketone does not rule out hyperinsulinism. Inappropriate high insulin level in a state of hypoglycemia, this is suggestive of or diagnostic of hyperinsulinism. So if you have the insulin level more than 2 microunit per ml, when the blood glucose level is less than 60, this is diagnostic of hyperinsulinism. The other cause is fatty acid oxidation defect. Will be no acidosis, no ketonemia, no ketonuria in a state of hypoglycemia, because the patient cannot utilize the fatty acids as an alternative fuel. And you will see the insulin level here will be appropriately suppressed. It means that the pancreas is not producing insulin in a state of hypoglycemia. So without acidosis, without ketosis, and the patient cannot use the free fatty acid or the fatty acid as alternative fuel. The lower half is hypoglycemia with acidemia. The possible cause is hypopituitarism or adrenal failure. And the lab here you will see ketonemia and ketonuria, low growth hormone and low cortisol in a state of stress and hypoglycemia, and you will see the insulin level is appropriately suppressed. The other cause is glycogen storage disease. It will be associated with ketosis, and you will see here the growth hormone and cortisol level will be high or will be elevated in response to the hypoglycemia, and the insulin level will be appropriately suppressed. The way to make the difference between exogenous hyperinsulinemia and endogenous hyperinsulinemia: this is exogenous hyperinsulinemia. This most commonly seen in patients with diabetes when they take extra insulin or they miscalculate their dose of insulin, or can be factitious, self-induced, or by guardian, and this considered child abuse. In this case, if you do lab, you should do the insulin and C-peptide in order to understand. In this case, you will see elevated insulin and low C-peptide if it's exogenous. If it's endogenous, which is hyperinsulinemia, this is very rare. Example of that, Beckwith-Wiedemann syndrome. Beckwith-Wiedemann syndrome associated with hypoglycemia, especially in the neonatal period. And the insulin level will be here elevated. So both of them have high insulin level, but the difference here that the C-peptide will be elevated in this case. If you have any child present with hypoglycemia, you need to repeat the blood glucose measurement every 15 minutes after any treatment until assured the euglycemia and the blood sugar is normalized. This is a summary for treatment of different cases of hypoglycemia. Acute hypoglycemia generally treated with oral glucose if the patient is conscious and able to drink, oral tablet or gel. If the patient in the hospital and requiring present with hypoglycemia and has IV access, IV dextrose will be better preferred over glucagon. If the patient is unconscious or unable to drink oral glucose, glucagon will be the option. Congenital hyperinsulinism, the pancreas is producing lots of insulin inappropriately. In this case, diazoxide will inhibit the release of insulin, the first line of treatment. Second line is octreotide, also will inhibit the release of insulin. Glucagon or pancreatectomy is the third option. Defect in fatty acid oxidation. These children, they cannot consume the fatty acid as alternative fuel. So they, to prevent the hypoglycemia, they have to avoid prolonged fasting. If they present with low blood sugar, immediate cake icing or oral dextrose is the best option. Sometimes even they present with seizure and coma, and in this case they will have to have IV dextrose. Ketotic hypoglycemia, these children, they present with recurrent hypoglycemia associated with ketosis and acidosis. In this case, these children, they should be provided with ketone strips, and they should be able to measure the ketone in their urine if they have nausea or they feel shaky or you suspect they have hypoglycemia. To prevent this case, they have to avoid prolonged fasting. And the treatment will be oral dextrose, cake icing if large urine ketone, anorexia, vomiting. If they are in the hospital, IV dextrose will solve the problem within few hours. Glycogen storage disease or glycogen release disease type 1, frequent feeding uncooked corn starch. In this case, you cannot give glucagon. It doesn't work. Growth hormone deficiency or cortisol deficiency, hormone replacement is the treatment. And in case of stress or illness, you need to triple the dose of glucocorticoid dose, and before surgery they should get the bolus or the treatment of glucocorticoid or IV hydrocortisone before surgery. Diabetes insipidus. Diabetes insipidus is diluted urine, passage of large volume of diluted urine, and the osmolarity of the urine will be less than 300. There is two types, central and nephrogenic. Central means the decreased secretion of antidiuretic hormone, ADH, and nephrogenic, they have antidiuretic hormone, but the kidney is not responding to this antidiuretic hormone, so inability to concentrate the urine because of resistance to ADH action in the kidney. Causes of central diabetes insipidus is idiopathic, is the most common cause. Trauma or surgery to the region of pituitary or hypothalamus, neoplasm or cancer of the brain, other causes like infiltration, like histiocytosis, infection, autoimmune or congenital diseases. Causes of nephrogenic diabetes insipidus is congenital X-linked or autosomal dominant nephrogenic diabetes insipidus. The next one is electrolyte disturbance. A drug like lithium is very common, democlocycline, urethral obstruction, chronic renal failure, polycystic kidney disease, and psychogenic. Clinical presentation of diabetes insipidus is polyuria, polydipsia, they love to drink ice water, irritability, failure to thrive, intermittent fever, and constipation. Diagnosis. This is very important to keep in mind. High serum osmolarity and low urine osmolarity is diabetes insipidus. So high serum osmolarity with low urine osmolarity is diabetes insipidus. So the serum osmolarity more than 300 and urine osmolarity less than 300 associated with hypernatremia is diabetes insipidus. Urine specific gravity in this case will be low, and the urine osmolarity usually less than 200 is a hallmark for diabetes insipidus. Polyuria and elevated plasma osmolarity despite a relative high basal level of ADH suggest nephrogenic diabetes insipidus. So if you have a similar case but the ADH level is high, this indicates that the kidney is not responding to the ADH. The treatment of diabetes insipidus for the central one is DDAVP or desmopressin. The treatment of nephrogenic diabetes insipidus, thiazide diuretics may be combined with amiloride and endomethacin. The follow-up is very important to keep in mind that idiopathic central diabetes insipidus must be followed because of possibility of a development of brain tumor or germinoma. So you have to have serial contrast enhanced brain MRIs every 3 to 6 months for the first 2 years, and thereafter also they need to be followed maybe every 5 years, because they can develop a cancer as late as even 20 years afterward. Syndrome of inappropriate antidiuretic hormone ADH secretion or SIADH. This is a case of hyponatremia, hypoosmolality, euvolemia or hypervolemia. Impaired water excretion or decreased urine output due to inappropriate high level of ADH. This is very common in hospitalized children. Common causes CNS diseases like meningitis, encephalitis, neurosurgery, hydrocephalus, head trauma. Pulmonary commonly associated with pneumonia, asthma, positive pressure ventilation, TB, cystic fibrosis. Neoplastic lymphoma and leukemia medication, for example, carbamazepine or oxacarbazepine. Clinical presentation of SIADH is euvolemia or hypervolemia, hyponatremia, and usually they are symptomatic if it's less than 125 mg. Anorexia, nausea, and malaise, or even coma. Diagnosis, you will see here the patient is having hyponatremia, low serum sodium less than 135, hypoosmolality, or the serum osmolality is low, less than 280. High urine osmolality is the hallmark for SIADH. For cases of diabetes insipidus, the urine osmolality will be low. In this case, the urine osmolality will be high. Low urine output or decreased urine output. SIADH commonly happen when patients are hospitalized. So if the patient having IV fluid, restriction of IV fluid will solve the problem in most of the cases. In more severe cases and symptomatic, 3% hypertonic saline will be the treatment option. But you need to pay attention to the increasing the sodium level rapidly. So you should increase the sodium level not more than 0.5 to 1 mg per hour. Also not more than 10 to 12 mg in the first 24 hours. And to bring the sodium value to a maximum 125 to 130, because of this severe complication can occur if you correct the sodium too rapidly, which is central pontine myelinosis. Cerebral salt wasting is because of hypersecretion of atrial natriuretic peptides. Can be associated with head trauma, hydrocephalus, common after head surgery, cranial irradiation, hypothalamic pituitary neoplasm, cerebral vascular accident, and brain death. So most of the cases is associated with brain or head problem. Clinical presentation is excessive salt wasting, a very high urine sodium. This is unique about cerebral salt wasting, and actually as usually you can memorize it with the name cerebral salt wasting. So they have a lot of waste of sodium in the urine, and hyponatremia. Diagnosis of cerebral salt wasting, you will have hypovolemic state. These children they have hypovolemia and they are usually dehydrated. Compared to SIADH, they are euvolemic or hypervolemic, because both of them they have hyponatremia. So the difference, this one will be dehydrated. The SIADH will have euvolemia or hypervolemia, because the treatment also will be different. High urine output, in the cases of SIADH, they have low urine output. Normal or high uric acid, high atrial natriuretic peptides. The treatment here is hydration. In the cases of SIADH, restriction of fluid. So it's very important to know the difference. Treatment of the underlying cause, serum sodium should be raised only enough to make the patient stable, 0.5 mg per hour, maximum 12 mg per liter per 24 hours. This table summarizes the difference between diabetes insipidus, SIADH, and cerebral salt wasting. For the cause here, for diabetes insipidus, low or resistance to ADH. For SIADH, they have elevated or inappropriately secreted ADH. In the cases of cerebral salt wasting is because of hypersecretion of atrial natriuretic peptides, very common after brain surgeries. Sodium level in the cases of diabetes insipidus is elevated. They have hypernatremia. In the cases of SIADH, it will be normal or low. The cerebral salt wasting, from the name, they have low sodium. Serum osmolality in the cases of diabetes insipidus will be high. So hypernatremia with high serum osmolality. In the cases of SIADH, will be hyponatremia with low serum osmolality. In the cases of cerebral salt wasting, the serum osmolality will be low. Urine osmolality in the cases of diabetes insipidus will be low. The SIADH, the urine osmolality will be elevated, and this is a big difference between both, so it's easy to recognize. In the cases of cerebral salt wasting, the urine osmolality will be relatively dilute because of the output, because of the high urine output. Intravascular volume, in the case of diabetes insipidus, they have hypovolemia, so they have high serum osmolality, hypovolemia with hypernatremia. In the cases of SIADH, they have euvolemia or hypervolemia. In the cases of cerebral salt wasting, they have hypovolemia, they are dehydrated. Urine output is high in diabetes insipidus, low in SIADH, high in cerebral salt wasting. Urine sodium is low in diabetes insipidus, high or match the sodium intake in the cases of SIADH. In the cases of cerebral salt wasting, the sodium in urine is very elevated, is more than 40 mg per liter. The management is different, so it's very important to know the difference. So the management in the case of diabetes insipidus is allowing the child to have access to free water all the time. As long as they have healthy water sensation or sensation to the thirst, they will stay alive. If you restrict the water from these children, they will die. So, and also the treatment will be, if it's central DDAVP, if it's nephrogenic, will be, for example, thiazide. In the cases of SIADH, the treatment restriction of fluid, restriction of the fluid. Cerebral salt wasting is the opposite. You have to provide fluid. You have to give them IV fluid to hydrate them, and they may need supplementation with oral salts. Prolactinoma. Prolactinoma is a prolactin secreting tumor. This is the most common cause in adolescents. Microprolactinoma is less than 10 millimeter in diameter. Macroprolactinoma is more than 10 millimeter in diameter. This is different between micro and macro. Less than 10, more than 10. Clinical presentation: headache, amenorrhea, galactorrhea. Visual disturbance of the tumor affects the optic chiasm, and they may present with bitemporal hemianopsia or total vision loss in severe cases. Diagnosis of prolactinoma is elevated serum prolactin, and you should perform TSH and pregnancy test in this case. MRI, if you have MRI positive for more than 10 millimeter of tumor, which is macroadenoma with a value of prolactin more than 200 or 200 or more, this is diagnostic of prolactinoma. Treatment is bromocriptine, but cabergoline is more tolerated than bromocriptine. We will move to a new subject: sexual development in children. Sexual maturity rating, or SMR. The sexual maturity or development in boys is start with enlargement of testes, is more than 3 ml or more than 2.5 centimeter. In the girls will be the breast buds. This followed by pubic hair in both, and then the height acceleration occurs later in boys. SMR 4 to 5, between SMR 4 to 5, and typically between age 13 and 14. For the girls, the height acceleration peaks earlier, between SMR2 and 3, and typically between age 11 and 12 years of age. The menarche usually follow the breast development by 2 to 2.5 years. So again, for the boys, the first thing is the testes. For the girls, the first thing is the breast buds. Quickly, we'll go over the sexual maturity rating and staging in boys and girls from stage 1 to stage 5. For the pubic hair, both girls and boys are the same. In stage 1, prepubertal, the second stage is sparse and lightly pigmented pubic hair. Third stage, increased in amount and darker and start curling. Stage 4, abundant, coarse, curly, but less than adult. It does not extend to the thigh. 5 extend to the thigh. So the difference here, the extension to the thigh, you should notice in your exam. In breast, the stage 1 prepubertal, stage 2 small mound and areolar diameter increases. Stage 3, the breast and areola are larger. no separation of breast contour is noted. For stage 4, you will see separation. Areola and papillae form secondary mound, and separation from the contour is noted. And they like to ask about this stage. So the key here is this separation. Stage 5, loss of this separation. So it will be on one contour. So the areola become part of the general breast contour, and you will see more projection of papilla. For the penis pre-pubertal stage 1, then scrotum and penis is enlarged slightly. In the stage 3, the testes and scrotum continue to grow. Stage 4, larger and darker, and the penis will increase in width. Then stage 5 is adult size. Abnormalities in the precocious puberty for boys if is less than 9 years of age is considered precocious. Causes a tumor. Very important for boys. If they have precocious puberty, you have to keep that in your differential tumors. For example, astrocytoma, hypothalamic hamartomas, acquired CNS injury like inflammation or surgery, congenital anomalies like, for example, hydrocephalus, adrenal tumor, drugs, for example, exposure to testosterone or estrogen. Precocious puberty in the girls less than 6 to 8 depends on the ethnicity. Breast enlargement, which may be the initial unilateral, so is a central precocious puberty is breast enlargement. In the boys will be enlargement of the testes and penis. This will be central, and it should be taken seriously. Pubic and axillary hair may appear before growth spurt and bone age. It will be advanced in girls. Precocious puberty in the boys less than 9 years of age. Central one will be testicular enlargement, a subtle finding that may often goes unnoticed by the patients and parents. Growth of penis and scrotum usually 1 year after accelerated linear growth and bone age advancement. Central precocious puberty should be suspected in boys with enlargement of genitalia, and for the girls with enlargement of development of the breast. Diagnosis: testosterone level is usually in boys with suspected precocious puberty is very useful to measure. DHEAS is usually elevated in boys and girls with premature puberty. Central precocious puberty, you should measure the LH after stimulation with gonadotropin releasing analog. Bone age will be advanced. MRI should be part of the evaluation for boys because of high risk of intracranial tumor, and for girls as well if you suspect a tumor. Management: surgical resection of the tumor and irradiation, and gonadotropin releasing hormone analog, not antagonist, analog. Bone age is the best initial study for final height prediction. So if you have a boy or a girl with precocious puberty and you want to determine the height or to assess the height or the final height, bone age is the best study. Bone age can be used to predict the final height. McCain-Albright syndrome is another cause of precocious puberty associated with cafe au lait pigmentation, and you will see segmental distribution like a map on the chest of dark skin. Polyostotic fibrous dysplasia usually associated with bone disease. You will have multiple pathologic fracture, visible bone deformity. If you do LH and FSH, they are below normal limits. They are below the normal limits. Plain radiography can show the multiple patchy areas of the bone lysis. Premature adrenarche is a common presentation. It's a benign and self-limited condition. It starts before age of 6 years of age in most of the cases. Early pubic hair appearance and axillary hair development, adult type body odor, but it's very important to make sure there is no sexual development, no breast development in girls, no testicular development in boys, because this will be central, not premature adrenarche. Also the growth pattern will be normal, and the bone age may be slightly advanced, but is not going to be advanced as in the cases of precocious puberty. Again, the bone age in the cases of premature adrenarche will be approximate the chronological age or slightly advanced. A slight increase in DHEAS level hormone, but is not severely elevated like in cases of adrenal tumor. Other adrenal steroid hormone are normal sex hormones, no congenital adrenal hyperplasia, so you will have normal 17-hydroxyprogesterone. Management is reassurance. Premature thelarche or early appearance of the breast in the girls. This is very benign in the first 2 years of life and requires reassurance. Possible underlying cause, if this appears after 3 years of age, must be investigated. The diagnosis, no lab work or imaging study is necessary if it happens before 2 years of age, in the first 2 years of age. After 3 years of age must be investigated. Management, benign condition is self-limited, require reassurance. Thelarche after 3 years of age again must be investigated. Thyroid gland. Causes of hypothyroidism and laboratory finding. Primary hypothyroidism, for example, thyroid dysgenesis and Hashimoto thyroiditis. TSH will be elevated and low free T4 in cases of primary hypothyroidism. So high TSH, low free T4. And in cases of Hashimoto thyroiditis, you will have positive antibodies, TPO and thyroglobulin antibodies. Subclinical hypothyroidism, you will have a slight elevation in TSH with normal free T4. Thyroxine binding globulin deficiency, normal TSH with low total T4 and normal free T4 and low thyroxine binding globulin level. If you do not order total T4, you will miss this diagnosis and luckily there is no treatment is necessary. Central hypothyroidism, the TSH will be reacting inappropriately to the low level of free T4. So it can be low, normal or slightly elevated. When you see the behavior of TSH is unusual to the low level of free T4, this is suggestive of central hypothyroidism. Cases of sick euthyroid syndrome, mild, moderate, and severe, they share low T3 and elevated reverse T3. In mild cases, you will have normal TSH with normal free T4. Moderate cases that you will have still normal TSH but low free T4. In severe cases, you will have low TSH and low free T4. So everything will be low except the reverse T3 will be elevated. Causes of decreased thyroxine binding globulin can be genetic or thyroxine binding globulin deficiency and is X-linked. Androgen also can do that. Glucocorticoid nephrotic syndrome because of loss of protein in urine. The causes of increased thyroxine binding globulin, oral contraceptive pills, pregnancy, hepatitis, medication, for example tamoxifen. Thyroid function in this case of decreased thyroxine binding globulin, you will see normal TSH and free T4. Also, in the other side, increased as a condition associated with increased thyroxine binding globulin, the TSH and free T4 will be normal. So both of them, they share this part. TSH and free T4 are normal in both cases, but in cases associated with decreased TBG, the total T4 will be low, and the cases associated with increased TBG, the T4 will be high. The management here, there is no treatment is necessary. Congenital hypothyroidism, thyroid dysgenesis is the most common cause of congenital hypothyroidism. Clinical presentation, most of the infants are asymptomatic, and you will know from the abnormal newborn screen. Length and the weight, they are normal, but the head may be larger than normal at birth. Prolonged physiologic jaundice should alert the clinician to possibility of hypothyroidism, especially if the child is not responding to phototherapy. Poor feeding, especially sluggishness, especially also if the child is not crying as much. Continue with the clinical presentation. Somnolence, choking spells during feeding may be the first sign in the first month. Large protruded tongue, apneic spells and noisy breathing, cold, mottled and dry skin, constipation, umbilical hernia, large anterior fontanelle, associated congenital anomalies, cardiac is the most common, and hypotonia. A laboratory study here is straightforward. TSH and free T4 you will order. The TSH will be elevated in classic cases of congenital hypothyroidism, will be in hundreds. Is not 12 or 15 or 13. It will be very elevated. And low free T4. No imaging study is necessary by most of the experts because it will not change the management. This is a newborn girl, had TSH 249, on her newborn screen. Thyroid function testing at 60 days of life showed TSH is 214 and the T4 is 3.2. What is the best next step? The best next step is to begin levothyroxine at dose 10 to 15 microgram per kg per day immediately. You don't want to wait for confirmation. You started the therapy and you can confirm afterward. It's very important. Every day the child is not receiving the medicine is losing IQ. Treatment of congenital hypothyroidism, start levothyroxine as early as possible. This given orally, and this is the treatment of choice. The dose is 10 to 15 microgram per kilo per day, the initial dose. No liquid preparation available for levothyroxine and should not be advised to give in liquid preparation for neonates and infants. How you can give it: crush and mix with water or breast milk. Never mix with soy milk, because of this will affect the absorption. Never mix with soy milk formula. Also do not mix with iron or do not take with iron and calcium, because this will interfere with the absorption. You have to advise the parents that you have to give total 7 doses per week. If you miss one dose in the second day, you can give double the dose in the second day with no problem, because the half-life of the levothyroxine is very long. So the goal is to give 7 doses per week. If you miss one day, you give in the second day the second dose. So you give 2 doses together with no problem. Prognosis: early diagnosis and treatment of congenital hypothyroidism prevents severe intellectual disability and other neurologic complications. So early treatment is critical. Hashimoto thyroiditis or autoimmune thyroiditis. It is autoimmune disease of the thyroid gland. Most common cause of hypothyroidism in children more than 6 years of age. More in girls than boys. It's about 2 to 3 times more in girls than boys. Usually you will see a positive family history. Clinical presentation of Hashimoto or autoimmune thyroiditis: goiter or asymptomatic goiter or large thyroid is the most common presentation. If it is associated with hypothyroidism, they may present with growth retardation, fatigue, constipation, dry skin, weight gain, depression, dementia, decreased school performance, cold intolerance, hair loss, menstrual irregularities, or galactorrhea. Physical examination: diffusely large, firm, and non-tender thyroid. In 30% the gland is lobular and may seem to be nodular. This is a case of Hashimoto thyroiditis for years old female with thyroid enlargement, fatigue, and daytime somnolence. The TSH in this case was more than 150 and the free T4 was less than 0.4. The anti-TPO or thyroid peroxidase antibodies were very high in this case. We started this child in levothyroxine, and actually afterward the thyroid size declined, and she started to look normal and feel much better after we started the levothyroxine. Diagnosis of Hashimoto or autoimmune thyroiditis. Thyroid function test is usually normal most of the cases. TSH can be normal, low, or elevated. Positive anti-TPO or anti-thyroid peroxidase antibodies, and positive anti-thyroglobulin antibodies. Management: follow-up labs every 6 months if euthyroid and no symptoms. If there is an evidence of hypothyroidism, you need to give levothyroxine. And if the patient is showing evidence of hyperthyroidism, propranolol and methimazole, it will be a good option. If there is a thyroid nodule, you need to do fine needle aspiration. This is a 10 years old girl with congenital hypothyroidism, is taking levothyroxine 75 microgram per day. Her labs always normal in the previous visits. During this visit, her TSH is 13.2, which is elevated, and the free T4 is 2.75, which is also elevated. What is the most likely cause of this lab, or what is the most likely explanation of this lab result? This lab result, elevated TSH and elevated free T4, means that this girl, before the lab is done, start to take the medicine more frequent. So the T4 is elevated, but the TSH is still elevated because of longer half-life. It takes time for the level to be established to reflect on the TSH. So it means that she's still hypothyroid, just she took more medication before the lab was done. So in this case, if you have high TSH with normal free T4, this means that the patient is not taking the medication. If you have high TSH with high free T4, means that this patient is taking lots of medication before the lab testing. This is the explanation of this case. This is common in the board, so know it by heart. Very important to know, once a patient started in levothyroxine, you have to, or if you modify the dose, you have to do a follow-up testing. But when to follow up? 6 to 8 weeks later. 6 to 8 weeks later. So you do TSH and free T4 should be measured 6 to 8 weeks later when you begin the treatment or you modify the dose, in order to see a good reflection of TSH by changing the dose or starting the medicine levothyroxine. Know that the half-life of levothyroxine is very long, is 5 to 7 days. So it takes a long time to have a steady level of levothyroxine in the blood. So also this will help us also to, when we advise the parents, when they miss one dose, they need to take it the second day, even 2 doses together. So if they are taking 75 microgram and they miss the dose in the previous day, they take 2 tablets in the second day with no problem, because the half-life is long. So they have to have 7 doses per week. If you have persistent elevation of TSH, this is not non-compliance. This is not non-compliance. Graves' disease. This is the most common cause of hyperthyroidism in pediatrics. This is mediated by thyroid stimulating immunoglobulin, TSI antibodies. This immunoglobulin mimic the action of TSH, so increase the size of thyroid and thyroid hormone overproduction. What is the most common symptom of Graves' disease? The most common symptoms is muscle weakness. Muscle weakness, know that. Clinical presentation of Graves' disease, again, weakness is the most common presentation. Enlarged thyroid, which can cause dysphagia if the thyroid is very large. Weight loss or muscle wasting, behavioral changes, diarrhea, palpitation, sleeplessness, heat intolerance, pruritus, exophthalmos, which usually mild in children, more common in adults. Upper eyelid retraction, infrequent blinking or still wax sign. Laboratory elevated free T4 and or T3. Suppressed TSH, sometimes free T3 is more elevated than T4. Antithyroid antibodies, TPO, are often present. Thyrotropin receptor stimulating immunoglobulin or TSI, this will confirm the diagnosis, and its absence usually means remission. Thyroglobulin will be low in exogenous thyroid and high in Graves' disease. So thyroglobulin will be low in exogenous thyroid intake and will be high or elevated in cases of Graves' disease. What is the most common side effects of methimazole? Transient urticarial rash. Transient urticarial rash is the most common side effect of methimazole. The most severe is agranulocytosis. So the most common is transient urticarial rash, and the most severe is agranulocytosis. Treatment of Graves' disease is methimazole. Methimazole is the most common antithyroid drug used in US. The side effects is again transient urticarial rash. This is the most common side effect. Agranulocytosis is more common in elderly. PTO or propylthiouracil is associated with severe liver injuries and is not used in US anymore for treatment of Graves' disease. Another option for treatment of Graves' disease is radioactive iodine, but this will be associated with permanent hypothyroidism, so all the patients, they will be on levothyroxine afterward. Beta blockers to blunt the toxic effect of circulating T4 and T3. Thyroidectomy if medication is not working or not tolerated. So surgery is not the first option, actually is the last option. Treatment follow-up, monitor the patient at 6 weeks to 3 months intervals with a thyroid function test, including TSH, total T4, free T4 level, liver function test, and CBC. Neonatal thyrotoxicosis is because of transplacental transmission of TSH receptor immunoglobulin from the mother to the fetus, and the TSI Immunoglobulin will stimulate the thyroid gland of the fetus and will produce extra thyroxine, and this can cause irritability, flushing, tachycardia, hypertension, thyroid enlargement, and exophthalmos in the neonate. The diagnosis: high T4 and T3, low TSH, and positive TSI, thyrotropin receptor stimulating immunoglobulin. The treatment in mild cases, symptomatic treatment with beta blocker, propranolol may be tried. In more severe cases, you need to give antithyroid medicine, which is methimazole. In severe cases, or in very severe cases, you will use iodide in the form of local iodine solution, or saturated solution of potassium iodide can be used. Prognosis usually resolve spontaneously in 3 to 12 weeks. Solitary thyroid nodules. Any thyroid nodules in children is more likely to be malignant. That's why it has to be investigated than in adults. Diagnosis: child history is very important, family history and radiation exposure. Thyroid function is usually normal. Ultrasonography is very important to determine whether the nodule is cystic, solid, mixed, or calcified. Fine needle aspiration biopsy is used for definitive diagnosis, and it's the study of a choice. Fine needle aspiration is not necessary or recommended in cases of toxic nodules. But so any child present with solitary thyroid nodules, they must go through this investigation: fine needle aspiration biopsy guided with ultrasound. Ultrasonography is very important to determine the shape of the nodule, if it's cystic, solid, mixed, or calcified. Again, the management of solitary thyroid nodule. All solitary nodules, including cold and non-toxic nodules, must be biopsied. After initial diagnosis and investigation of the thyroid nodule, medical and or surgical therapy is decided. Close observation is very important and follow-up is essential. So again, to emphasize on the importance of this part, palpable thyroid nodule, or if it's more than or equal 1 centimeter, on imaging study. So if it's palpable, if you can feel it, or in the imaging study more than or equal 1 centimeter, on the imaging study or ultrasound, the next step is thyroid ultrasound guided fine needle biopsy. If it's smaller than that, but if there is anything to suggest malignancy, you have to biopsy. If it's less than 1 centimeter, but if it's calcified or irregular border or increased blood flow on the Doppler ultrasound, also must be biopsied. Thyroid cancer. History of radiation or neck radiation increases the risk of thyroid cancer. Papillary carcinoma is the most common type of thyroid cancer. High rate of regional and distant metastasis. That's why early diagnosis is very important. Multiple endocrine neoplasia type 2 is autosomal dominant and commonly associated with thyroid cancer. Types of thyroid cancer: follicular cell origin, papillary cell carcinoma, and follicular cell carcinoma. Medullary thyroid cancer can be associated with multiple endocrine neoplasia type 2. We have MEN2A and MEN2B. In MEN2A, you will have medullary thyroid cancer, pheochromocytoma, hyperparathyroidism. MEN2B the same, except instead of hyperparathyroidism, you'll have mucosal neuroma. Clinical presentation is a neck mass and is painless, usually detected by the parents or the physician during the routine physical examination. Diagnosis: biopsy will confirm the diagnosis. Calcitonin level is elevated in medullary thyroid cancer type. Abnormal biochemical lab if is associated with MEN type 2 because of medullary thyroid cancer. For example, hyperparathyroidism, they will have high or elevated calcium level and low phosphorus. Elevated calcium level and low phosphorus if is associated with MEN type 2. Management: TSH suppressive therapy in children with papillary or follicular type thyroid cancer. Surgery, radiotherapy, surveillance, prophylactic removal of thyroid if positive oncogene gene mutation for MEN2A in 5 years and for MEN2B in 6 months. Thyroid storm is a thyrotoxic crisis because of excessive release of thyroid hormones, and this can cause acute and life-threatening hypermetabolic state. The clinical presentation: fever, and this is one of the differential diagnosis in a child present with high fever and with no explanation, you should keep thyroid storm in your differential. Profuse sweating, poor feeding and weight loss, respiratory distress, nausea and vomiting, abdominal pain, seizure and coma. Diagnosis of thyroid storm is elevated T3 and T4, suppressed TSH. The treatment corrects the electrolyte abnormalities, propranolol or anti-adrenergic to control the sympathomimetic symptoms. Aggressive control of fever and hyperthermia, high dose of propylthiouracil PTU. In this case, PTU will be preferred because of a faster action over the methimazole. Methimazole can be used in less severe cases. Calcium and bone disorders. I will start this section with hypocalcemia. Hypocalcemia means low total calcium, less than 8.5 milligram per deciliter in children, less than 8 in neonates, full term, and less than 7 in preterms. Causes during newborn period, prematurity is the most common cause of hypocalcemia. Diabetes mellitus in the mother or gestational diabetes because of depletion of magnesium. Magnesium deficiency also can cause hypocalcemia. Transient hypoparathyroidism of newborn. During childhood or in children, hypoparathyroidism, vitamin D deficiency, resistance to the action of vitamin D, pseudo hypocalcemia because of hypoalbuminemia. So always you need to correct the calcium level for low albumin. Clinical presentation of hypocalcemia, lethargy, tetany, seizures. It's very important to check electrolytes for any child present with new onset of seizure. To make sure it is not electrolyte disturbance before going for EEG or imaging study. Covestic sign, which is facial twitching by gently tapping the course of the facial nerve in front of the ear. Trozway sign, which is can be elicited by inflating the blood pressure cuff 20 millimeter of mercury above the obliteration of the radial nerve for 3 to 5 minutes. This can cause carpal spasm. Also prolonged QT interval is one of the manifestations of hypocalcemia, so ECG or AKG is important. Hypoparathyroidism is a condition because of deficiency of parathyroid hormone. This can happen because of accidental removal of parathyroid gland during thyroid surgery. Congenital causes, for example, DiGeorge syndrome, autoimmune polyendocrinopathy, candidiasis, ectodermal dystrophy, Wilson disease, hemochromatosis, hypomagnesemia. Maternal hypercalcemia in unborn infants may cause suppression of parathyroid hormone in neonates. A clinical presentation of hypoparathyroidism similar to hypocalcemia plus the manifestation of the underlying condition. Paresthesia involving the fingertips, toes, and perioral area, hyperirritability, seizures, hoarseness, and muscle cramps. Diagnosis of hypoparathyroidism. Primary hypoparathyroidism, you will see low PTH and low calcium level. Both of them are low. Pseudo hypoparathyroidism, the PTH is high, but because of resistance and PT receptor mutation, in this case, the calcium will remain low because the PTH is high but is not working. Secondary hypoparathyroidism, the PTH is low, but why? Because the calcium is high. So is a reflex. So secondary hypoparathyroidism. Diagnosis of hypoparathyroidism, calcium, serum, magnesium, and phosphorus level. These labs should be ordered for any suspected metabolic bone disease, because without phosphorus, you will not be able to understand the problem with calcium. So phosphorus is very essential to order with calcium in order to understand any metabolic bone diseases. Parathyroid hormone level, 25 hydroxyvitamin D to exclude vitamin D deficiency as a cause of hypocalcemia. Management to correction of hypocalcemia with vitamin D. You need to use the active form of vitamin D because you have deficiency of parathyroid hormone, which is necessary for activation of vitamin D in the kidney to calcitriol. So it's important to use that because without regular vitamin D like 25 hydroxyvitamin D will not work because it is not the active form of vitamin D. You need PTH in order to activate the vitamin D and is already deficient. Pseudo hypoparathyroidism, Albright hereditary osteodystrophy. Clinical presentation, hypocalcemia, can present in infancy and tetany. In cases of Albright hereditary osteodystrophy, type 1 usually characterized by short stature, stocky habitus, round face, brachymetacarpals, dimpling over the knuckles of clenched fist due to short metacarpals, brachymetatarsus, intellectual disability, and subcutaneous calcifications. Very common in the board. Diagnosis: high serum PTH and low serum calcium and high serum phosphate. And also skeletal defect is a classic finding in this case. Management: to all patients with severe symptomatic hypocalcemia should be initially treated with intravenous calcium, oral calcium, and calcitriol, similar to hypoparathyroidism. Familial hypocalciuric hypercalcemia or familial benign hypercalcemia is a benign condition, is autosomal dominant, asymptomatic, usually discovered incidentally on routine lab done for other reason. Diagnosis: hypercalcemia with calcium level more than 10.2 mg per deciliter, and urine calcium to creatinine ratio is normal, and urine calcium is less than 200 mg per day, normal PTH and normal phosphate. The treatment: there is no treatment is necessary. Let's take a break with one case. This is an 8-year-old boy with 3 months polyuria, intermittent back pain, constipation, mild hyporeflexia. Total calcium is 12.3 mg per deciliter and the phosphorus is 1.7 mg per deciliter. What is the best test to establish the diagnosis of this case? So this is a child with polyuria, back pain, constipation, high calcium, and low phosphorus. The best test to establish the diagnosis in this case is serum parathyroid level. When you have high calcium and low phosphorus, this is hyperparathyroidism. This is hyperparathyroidism, and in order to establish this diagnosis, you need to order serum parathyroid hormone. Hyperparathyroidism is rare in children. Primary hyperparathyroidism, usually caused by single adenoma, which is the most common cause, can be associated with multiple endocrine neoplasia syndrome, MIN1 or MIN2A. Secondary hyperparathyroidism can occur with chronic renal diseases, cholestatic liver disease, or iatrogenic, for example, lithium. Clinical presentation of hyperparathyroidism is related to the hypercalcemia, commonly present without symptoms: hypercalcemia, muscular weakness, bone pain, abdominal pain, acute pancreatitis, and nephrolithiasis. Diagnosis of hyperparathyroidism: serum calcium level more than 12 mg per deciliter, low serum phosphorus less than 3 mg per deciliter, or it depends on the age. Is very important to consider the phosphorus level according to the age because it varies. High PTH or high level of parathyroid hormone and normal calcitonin level. Management of hyperparathyroidism: for primary hyperparathyroidism, subtotal or total parathyroidectomy is the most common choice for adults and children. Calcitriol may help in cases of chronic renal failure. Treatment of acute severe hypercalcemia with the calcium more than 14. Intravenous hydration, loop diuretics, for example furosemide after hydration, and hemodialysis in severe cases. Neck, knees, and bow legs can be normal and physiologic in children. Bow legs or a physiologic virus seen in children less than 2 years of age and resolve spontaneously, and geniovalgum or neck knees can be seen in children around 3 years of age and resolve by 8 years of age. So it's not necessary when you see that is rickets. Red flags if the distance between the condyles is far more than one hand, and also between the malleolus intramallular distance is more than one hand, rapidly progressive abnormal gaits or developmental delay, or any other red flag of metabolic bone disease. Rickets occurs in growing children. Causes of rickets: prolonged and exclusive breastfeeding without vitamin D supplementation, especially if no sunlight exposure. Intestinal malabsorption of fat because vitamin D is a fat soluble vitamin. Liver or kidney diseases. Anticonvulsant drugs like phenobarb. Vegan diets, especially lacto-vegans, and genetic causes, which is rare. Clinical presentation of rickets. Suspect rickets in an infant presents with seizure, exclusively breastfed, especially around 9 months of age. I had this case before, and the initial lab work was electrolytes and the calcium was low and vitamin D was extremely low. And this is common to present in very young ages. It presents with hypocalcemia, muscular hypotonia, and motor developmental delay. Craniotapes, which is area of thinning and softening of bones of the skull. Frontal busing and also the anterior fontanelle closure will be delayed. Bow legs and knock knees. Rachitic rosary along the costochondral junction. Also, rickets can present with Harrison groove, which is the pulling of the ribs by the diaphragm, and the ribs are weak, so it will give a shape of groove at the site of the attachment of the diaphragm. Kyphoscoliosis, knobby deformity of the long bone, can be visualized also in the radiograph as a cupping and a flaring of the metaphysis. Marfan sign. If you palpate the tibial malleolus, this will give impression of double epiphysis. It's called Marfan sign, and the green stick fracture. The diagnosis of rickets require laboratory finding and radiographic finding as well. So you need both in order to diagnose rickets. The classic laboratory finding in nutritional rickets: low to normal calcium, low phosphorus, low 25-hydroxy vitamin D, high alkaline phosphatase, and high parathyroid hormone. This is an X-ray for a 3-year-old boy. This is for the wrist and one for the leg. If you look at the physis here is wide, very wide, and also with cupping and fraying, and is not easy to see the end of the bone, so it's not really clear, and this is very classic with rickets. Radiologic finding is very important for the diagnosis of rickets. The best study is to study the knee, the anterior view of the knee. Also, you can study the wrist and the ankle, which is the end of long bones. Widening and cupping of metaphysis is classic. Fraying of metaphysis. Epiphyseal plate is widened and irregular. So I remember that rickets occurs only in growing children, not in adults. And also osteopenia may be noticed on the X-ray. Management of rickets is vitamin D and calcium replacement. Vitamin D is the main therapy for treatment of rickets, and you should start a high dose, average 2,000 to 3,000 international unit for 2 to 3 months to replenish the stores of vitamin D, and until the healed X-ray is observed. When labs normalize and radiological finding shows healing, the vitamin D dose can be reduced to 400 international unit per day. Follow up labs and X-ray in 3 months from the therapy is very important. If there is no response to regular vitamin D, look for rare causes of rickets. Calcium replacement, hypocalcemia should be treated with calcium supplementation, especially during therapy. Prevention of vitamin D deficiency: 400 international unit of vitamin D per day should be given after birth for all breastfed infants. And non-breastfed infants and children who do not ingest at least 1 liter of vitamin D fortified milk daily. 800 international unit, which is double the dose for premature infants, dark skinned infants and children, or if resides in high altitudes. This table is to explain the relationship between calcium and phosphorus level and the most likely diagnosis. If you have low calcium and low phosphorus, vitamin D deficiency. High calcium, high phosphorus, excess intake of vitamin D. High calcium, low phosphorus is hyperparathyroidism. Low calcium, high phosphorus is hypoparathyroidism. Hypophosphatemic rickets, X-linked hypophosphatemic rickets. It is X-linked dominant and affects both males and females. Clinical presentation: failure to thrive, hypotonia, reluctance to bear weight when beginning to stand or walking, delayed dentition. Diagnosis of hypophosphatemic rickets: the calcium level will be normal, but the phosphorus level will be low. But this can be easily missed because of the normal reference range on the lab results you will have. So it's very important to adjust the reference range for age. So in infants, the normal level of phosphorus between 5 and 7.5 compared to the adult, which is 2.7 to 4.5. So if you have a child with phosphorus level 3, this is considered low. If you have an infant with phosphorus level is 4, this is considered low for this infant. So this can be easily missed in babies because of reference range. Very high alkaline phosphatase is expected to be seen in hypophosphatemic rickets. It will be in thousands, like 2,000, 3,000 in hypophosphatemic rickets if you compare it to nutritional vitamin D deficiency, which will be elevated but not in thousands as hypophosphatemic rickets. In cases of X-linked hypophosphatemic rickets, the bicarb will be normal. But in cases of Fanconi syndrome or oculocerebrorenal dystrophy Lewis syndrome, the bicarb will be low, and this will be non-anion gap metabolic acidosis. Radiography or radiographic finding will be the same as vitamin D deficiency rickets. Management is calcitriol or active form of vitamin D and phosphorus. Cushing syndrome. Cushing syndrome is caused by prolonged exposure to a high level of endogenous glucocorticoid from inside the body or exogenous from outside, like taking medication containing steroids. Cushing syndrome in infants is mostly caused by functioning adrenocortical tumor. Pituitary tumor or ectopic ACTH secreting tumor is rare in children. Clinical presentation: excessive weight gain, especially in the face, supraclavicular region and the upper back, failure to grow or short stature. So if you have obese and short is a red flag for Cushing syndrome. Obese and short. You remember that obese, regularly or normal obese, they are tall, not short. But with Cushing syndrome, they are short. And hypertension is a red flag as well. Cushing syndrome may also present with purple stretch marks, easy bruising, and other signs of skin thinning, proximal muscle weakness, depression, cognitive dysfunction, and emotional lability also may develop. Diabetes mellitus or glucose intolerance decrease the bone density and fractures. Diagnosis of Cushing syndrome: 24-hour urine-free cortisol is the best initial screening test for Cushing syndrome. On the CBC, you may see leukocytosis. Also, this patient may have hyperglycemia or glucose intolerance, hypokalemic metabolic alkalosis. Dexamethasone suppression test if the diagnosis is unclear. Abdominal CT or MRI if adrenal neoplasm is suspected. Brain MRI if pituitary tumor is suspected. Management of Cushing syndrome depends on the lesion and location. Unilateral adrenalectomy for benign adrenal tumor. Transsphenoidal pituitary microsurgery is the treatment of choice for pituitary adenoma. Addison disease: it's adrenocortical insufficiency because of destruction or dysfunction of the entire adrenal cortex. Idiopathic autoimmune Addison tends to be more common in girls than boys. Associated autoimmune diseases: patients with type 1 diabetes may develop Addison disease. This is very important to remember. Celiac disease as well, Hashimoto thyroiditis, Graves' disease, alopecia areata totalis and universalis, premature ovarian or testicular failure, pernicious anemia, vitiligo, autoimmune polyglandular syndrome type 2. Other causes of Addison disease: tuberculosis, sarcoidosis, histoplasmosis. Causes of acute adrenal insufficiency or adrenal crisis: severe sepsis, like in cases of meningococcemia, which can cause vasculitis and bilateral adrenal hemorrhage. Failure to increase the dose of steroids in the patients who, for example, with adrenal insufficiency, like congenital adrenal hyperplasia in the time of stress, like surgery, or the patient did not triple the dose when they are ill or having fever. Scrotal hematoma also can cause that. What is the most common symptom of adrenal insufficiency? The most common symptom of adrenal insufficiency is nausea. Remember that. Clinical presentation of Addison disease: hyperpigmentation because of high ACTH, vitiligo, hypotension, myalgia, and flaccid muscle paralysis may occur due to hyperkalemia. Adrenal crisis: the patient will have nausea, vomiting, vascular collapse, shock, and may appear cyanotic and confused. Acute abdomen, high fever with temperature may reach up to 105 Fahrenheit or higher. Diagnosis: serum cortisol level is the best initial test for a patient with suspected Addison disease. Random cortisol more than 20 microgram per deciliter rule out the disease. So if you have high cortisol, level, this will rule out the disease, especially in the cases of stress. Rapid ECTH stimulation test also will confirm the diagnosis. Low cortisol with elevated ECTH is suggestive of Addison disease. Also, the patient will have hyponatremia and hyperkalemia. And also, you may present in the exam with AKG for the manifestations of hyperkalemia on the ECG. Diagnostic labs in cases of adrenal crisis. Low serum cortisol measurement during the time of acute illness. This will confirm the diagnosis of adrenal insufficiency. Meanwhile, also you will see the patient having low aldosterone level, hypoglycemia, hyponatremia, hyperkalemia, and high ECTH and renin. Management of adrenal crisis. IV fluids and rapid volume expansion. This is a case of emergency. Monitoring of sugar and electrolytes. IV bolus of hydrocortisone. This is the treatment. IV bolus of hydrocortisone, 50 to 75 milligram per meter square, followed by 50 to 75 milligram per meter square per day, divided over 3 times or 4 times until resolution of crisis. Management of adrenal insufficiency is oral hydrocortisone, 9 to 12 milligram per meter square per day, then mineralocorticoids, which is fludrocortisone, 0.1 to 0.0 milligram per day. This is in cases of salt losing. Stress dose, triple the daily oral dose in cases of fever or illness. Hydrocortisone should be available in cases of emergency for the patients for intramuscular injection if symptomatic like vomiting. If not responsive, they should call 911. This table is to differentiate between primary adrenal insufficiency and secondary adrenal insufficiency. In the primary adrenal insufficiency is a disorder of the adrenal gland, and the secondary adrenal insufficiency is disorder of pituitary or hypothalamus. In the primary adrenal insufficiency, you will have the ECTH will be elevated, associated with hyperpigmentation. In the secondary cases or secondary adrenal insufficiency is associated with low ACTH and no hyperpigmentation. So the pigmentation of the skin here will make the difference, and the level of the ACTH. Iatrogenic adrenal insufficiency, commonly seen in the patients with severe asthma receiving a high inhaled dose or oral steroid, or patients receiving oral steroid for a long time, like in cases of nephrotic syndrome. Withdrawal of steroids suddenly, this can cause adrenal insufficiency. Patients may present with nausea, vomiting, muscle weakness, and hypotension. Laboratory may show hypoglycemia, low sodium, and in this case the potassium will be normal. Prevention. To wean off the medicine over a long time, almost equal to the time the patient received the medicine, and this typically more than 2 weeks. Let's take a break with this case. This is a 9-year-old boy presents with feeling tired all the time, muscle weakness, loss of appetite, frequent falls, and dementia. Physical examination is significant for skin hyperpigmentation, decreased muscle strength, and ataxia. So there is a neurological problem. BMP is significant for low sodium and high potassium. What is the best diagnostic lab in this patient? The best diagnostic lab in this patient is very long chain fatty acid level. So this is a classic presentation of adrenoleukodystrophy, which is usually occurs in boys because it's X-linked, associated with very long chain fatty acid deposits in the adrenal gland and CNS. So it causes adrenal insufficiency and neurological disorder as well. So adrenal insufficiency, skin hyperpigmentation if the adrenal is involved. This patient may present with ataxia, hearing loss, and vision loss, and eventually death. The MRI will show periventricular demyelination. The key word for adrenoleukodystrophy is boy, because it's X-linked adrenal insufficiency combined with neurological disorder. Pheochromocytoma is a rare benign tumor of the adrenal medulla, produces lots of catecholamines. Clinical presentation of pheochromocytoma: headache. This is the most common presentation, followed by sweating, nausea, and vomiting. Hypertension is a very common presentation as well. Palpitation, tremor, weakness or exhaustion, nervousness, or anxiety. Diagnosis of pheochromocytoma clinically and by measurement of the urinary catecholamines, homovanillic acid, vinyl mandelic acid, epinephrine, norepinephrine, abdominal ultrasound for detection of the tumor in the adrenal. If it's not, MRI will be the best option and preferred over the CT scan in the children. Management of pheochromocytoma, treatment of pheochromocytoma surgical removal, but they have to have a pre-treatment with alpha blockade with phenoxybenzamine first before any beta blockers to prevent hypertensive crisis. If the patient develop hypertensive crisis, they will need alpha blockade, phenoxybenzamine. Nitroprusside or aggressive antihypertensive medicine can be used if the blood pressure is uncontrolled. We'll start a new section, disorders of sexual development, or DSD, disorders of sexual development. This is a general approach for any newborn presents with ambiguous genitalia. History is very important. Family history of females who are childless or have amenorrhea. Also a history of exposure to androgens, a history of consanguinity. A physical examination with careful description of genitalia is very important. Also palpation of gonads, if the gonads is palpable or not. This can be a key for diagnosis of many conditions. Also sex hormones is very important, especially the 17-hydroxyprogesterone need to be ordered early in females with suspected congenital adrenal hyperplasia to prevent the consequences of adrenal insufficiency. Pelvic ultrasound to look for Mullerian structural uterus or fallopian tubes, and also for intra-abdominal gonads or testes. Karyotype to determine the original sex of the child is very important. Consultation of pediatric endocrinologist, urologist, psychologist, social services. It is a really difficult, complicated situation. Needs a team with experience in this issue of disorders of sexual development. Here just a reminder with the new terms of ambiguous genitalia. Hermaphrodites is not used anymore. What is used now? Disorders of sexual development instead of hermaphrodites. So female pseudohermaphrodites now is 46XX DSD, and male pseudohermaphrodites is 46XY DSD. True hermaphrodites, which is ovotesticular DSD, where they have ovaries and testes, maybe over in one side and the testes on the other side. XX male 46XX testicular DSD. When you present with the questions about ambiguous genitalia, the most common cause of ambiguous genitalia, you need to verify if it's for boys or girls. The most common cause of ambiguous genitalia in females is congenital adrenal hyperplasia. The most common cause of ambiguous genitalia in males, in boys, is androgen insensitivity. So when you present with this question, you have to verify if it's for females or males. For females is CAH or congenital adrenal hyperplasia. The most common cause in boys is androgen insensitivity. Why? Because boys with congenital adrenal hyperplasia, they have normal male genitalia. Very important, with palpable gonads. Congenital adrenal hyperplasia, this is the most common cause of ambiguous genitalia in females. So it is autosomal recessive. This is actually the most common, generally the most common cause of disorders of sexual development, is about 60%. Classic example is 46XX DSD in females, which is used to be known as female pseudohermaphrodites. Causes: 21-hydroxylase deficiency, the most common, 17-hydroxylase deficiency, 11-beta-hydroxylase deficiency, and 3-beta-hydroxysteroid deficiency. 21-hydroxylase deficiency, if the difference between boys and girls in the classic type, salt wasting type, which is the most common. Salt wasting type, which is the most common. For genitalia and the girls, they will be able to identify early after birth because of ambiguous genitalia. For boys, their genitalia looks normal, so they will present later with vomiting, dehydration, shock, failure to thrive, misdiagnosed with pyloric stenosis or sepsis, hyponatremia, hyperkalemia, hypoglycemia. In 21-hydroxylase deficiency non-salt wasting type, for the girls it also will be very easy to identify after birth because of ambiguous genitalia. For boys, the presentation will be late because of normal genitalia. and usually 6 months or more they will present with androgen change from the adrenal, pubic hair, body odor change, acne, testes usually are pre-pubertal. Rare causes of congenital adrenal hyperplasia: 11 hydroxylase deficiency, 17 hydroxylase deficiency, 3 beta hydroxysteroid dehydrogenase deficiency, which is extremely rare. The 11 and 17, they share one thing, which is hypertension. Both of them, they are associated with hypertension. And this can be differentiated easily from 21 hydroxylase deficiency, which is usually associated with hypotension. So, but the difference between 11 and 17, that 11 associated with androgen excess and 17 with androgen deficiency. So females in 11 hydroxylase deficiency, they will have virilization, or they will be virilized. In males, they will have precocious puberty. In cases of 17 hydroxylase deficiency, the males, they will have ambiguous genitalia. Females, they will have sexual infantilism. So they look normal at birth. They will have delayed puberty and lack of secondary sexual characteristics. And in cases of 3 beta hydroxysteroid, they present with ambiguous genitalia. The lab to confirm for 11 hydroxylase deficiency increased deoxycorticosterone, and for 17 hydroxyprogesterone, they have elevated mineralocorticoid. If there is a concern about congenital adrenal hyperplasia, you are able to do prenatal diagnosis. Molecular testing for 21 hydroxylase with chorionic villus sample at 10 weeks and amniocentesis at 18 weeks. Diagnosis, most of the time you will see the positive newborn screen for 17 hydroxyprogesterone, and the number usually will be in thousands for the classic cases of congenital adrenal hyperplasia. But if it's slightly elevated, like 10 or 20 or 30 above the normal, you need just to repeat. But classic cases, they have the number in thousands, big number, not just 10 or 13 or 20 above the normal value. Diagnosis, also you will see low serum aldosterone, hyponatremia, hyperkalemia. Karyotype, it is essential in evaluation in infant with ambiguous genitalia to establish the patient's chromosomal sex. Management of congenital adrenal hyperplasia: IV fluid if presenting with shock or dehydration. Dextrose to correct for hypoglycemia. The principle of treatment is hydrocortisone. 50 to 100 milligram per meter square, or 1 to 2 milligram per kilo initial dose if signs of adrenal insufficiency, for example hypotension. This should followed by maintenance dose of 50 to 100 milligram per meter square, IV divided every 6 hours until the crisis resolve. Long-term management: hydrocortisone oral, not preferred over the other steroids. Hydrocortisone is the best option. Triple the dose in cases of stress or illness. This is very important to prevent adrenal crisis, fever or illness, or if the child feeling sick. Fludrocortisone, the dose is 0.05 to 0.2 milligram per day, PO to the patients with mineralocorticoid deficiency. Oral salt also can be given in infants with salt wasting form. 46XX DSD is previously female pseudohermaphrodites, which is simply a female partially or completely virilized because of endogenous androgen or exogenous androgen exposure. For exogenous is excessive androgen exposure, like for example danazole. Endogenous, for example, cases of congenital adrenal hyperplasia. Exposure to androgen during a pregnancy, this can cause labial fusion if it's early exposure. Late exposure can cause labial fusion with clitoral enlargement, in between clitoral enlargement. 46XY DSD, previously well known as male pseudohermaphrodites. The karyotype is 46XY. It is under virilized male. Most common cause is androgen insensitivity. You need to remember that. Most common cause of under virilized male or male pseudohermaphrodites is androgen insensitivity. It is very difficult to diagnose, mostly raised as female. Dennis-Drash syndrome is a classic example of 46XY DSD or male pseudohermaphrodites. Testicular function deficiency, so there is no MIS, there is no Mullerian inhibiting substance. So in this case, they will develop uterus fallopian. So the intra or the abdominal structure, it will show female uterus fallopian. Clinical presentation: nephropathy, renal failure, usually by 3 years of age, ambiguous genitalia, and Wilms tumor. Weger syndrome is a classic example also of 46XY or male pseudohermaphrodites. They miss one copy of 11B13. They presents with Wilms tumor, aniridia, genitourinary abnormalities, and intellectual disability. R used to be for retardation, but now we are using intellectual disability. So again, Wilms tumor, aniridia, genitourinary abnormalities, and intellectual disability. Weger syndrome. Remember this syndrome. Gonadal differentiation and internal genitalia. Very important to understand this slide. This will make it easy to understand the next few cases. Simply, female do not need anything to develop. If you let go, everything will develop female. But what will make the difference is the Y chromosome. Y chromosome with intact region of SRY. This will stimulate the Leydig cell to produce testosterone, and the testosterone will stimulate the Wolffian ducts to develop epididymis, vas deferens, and seminal vesicles. Without testosterone or without Leydig cells, this will not develop. So if you have insensitivity to the testosterone, none of that will develop. The person will look like female external genitalia. Also, this will stimulate the Sertoli cells to produce MIS, which is Mullerian inhibiting substance. This will inhibit the female internal organs to develop, which is the Mullerian duct. If there is no MIS is produced from the Sertoli cells, or insensitivity to or resistance to the Mullerian inhibiting substance, internal female genitalia will develop. So if you do not have Sertoli cells producing or stimulated to produce MIS, everything inside will develop female. Will have uterus, fallopian tube, and upper vagina. But in order for you to not to have this internal structure, you have to have MIS, Mullerian inhibiting substance. And this is the function of SRY and Y chromosome. So the Y chromosome and the SRY, they will stimulate the Leydig cell to produce testosterone. Testosterone will stimulate the Wolffian ducts. Then you will have external male genitalia. And for Sertoli cells, it will produce MIS, Mullerian inhibiting substance. It will inhibit and prevent the female internal structure to develop. Also, this part is very important, differentiation of external genitalia, because you will have condition may affect the this enzyme. So you need the testosterone to develop external genitalia. So external genitalia will appear phenotypically female if you do not have testosterone or insensitivity to this testosterone, like in cases of androgen insensitivity. And also testosterone need to be converted to dihydrotestosterone. And if you do not have a 5-alpha reductase, like in cases of 5-alpha reductase deficiency, you will not have development, or you will have external ambiguous genitalia. So in order to develop the external genitalia, you need to have intact enzyme to convert the testosterone to dihydrotestosterone to develop the scrotum, the shaft of the penis, the glans, and the prostate. Let's start with a clinical case scenario. This is 16 years old female presents to your clinic because of amenorrhea. Physical examination is significant for breasts are Tanner 4, so she has breast. Blind vagina, no pubic hair, no axillary hair. The ultrasound, no intramullerian structure, no fallopian tube, no uterus. But she has intra-abdominal testes. The karyotype is XY. And the testosterone level is high. So the key word here in this case is a XY female phenotype, no Mullerian structures, no uterus, no fallopian. She has a benign vagina, amenorrhea, and no sexual hair, and she has high testosterone. So this is a classic case of androgen insensitivity syndrome. It is X-linked disorder. It is due to defect in androgen receptor gene. All infants are 46XY. All infants have testes and normal or high testosterone levels. Clinical presentation: infants is phenotypically female at birth because of androgen insensitivity. So if no sensitivity to the testosterone, the external genitalia will develop as female genitalia, but they will have blind end vagina because they have intact MIS, which is Mullerian inhibiting substance. So it will be no uterus, no fallopian tube will develop because you have normal MIS. So MIS will inhibit the development of internal female structures. Testes are usually intra-abdominal. At puberty, they develop breast normally, but no menses. Why they develop breast? Because high testosterone level will be converted to estrogen, and they will develop breast, and this will be confusing a little bit. Sexual hair does not appear because they are insensitive to the androgen. So testosterone again is usually elevated, and it will be converted to estrogen, and at the end they will develop breast. This is a 16 years old female presents to your clinic because of absence of breast and menses. On physical examination, she has no breast but has vagina. Ultrasound showed a normal intramullerian structure, which is uterus, fallopian tube, but she has streaks of gonads. Karyotype is XY. What is the most likely cause? The key word here is a female appearance and structure. So externally is female and internally also female structure with no secondary sexual characteristics. Swyer syndrome or XY pure gonadal dysgenesis. Most of the patients, they have mutation in SRY gene, but the Y chromosome itself is cytogenically intact. But you need SRY gene to develop Leydig cells and Sertoli cells. But in this case, you have mutation in the SRY gene, so no Leydig cells, means no testosterone, means no Wolffian structures, no external male genitalia. Also will be no Sertoli cells. When you do not have Sertoli cells, it means that you do not have MIS. When there is no MIS, which is Mullerian inhibiting substance, the internal female structure will develop. So this patient will have internal Mullerian structure like uterus and fallopian. The gonads are undifferentiated streaks. Clinical presentation of Swyer syndrome or XY pure gonadal dysgenesis is complete female phenotype, internal and external, presence of vagina, uterus, and fallopian tubes. At puberty, they do not develop breast and no menstruation, and they have streaks of gonads. Prognosis: development of gonadoblastoma is the highest risk, so the gonads has to be removed. So the management: gonads must be removed as soon as the diagnosis is made because of risk of gonadoblastoma. This table is to differentiate, to make it easy to know the difference between androgen insensitivity syndrome and Swyer syndrome, XY pure gonadal dysgenesis. The cause in androgen insensitivity, defect in androgen receptor, and is X-linked. Here in Swyer is mutation in SRY gene. Karyotype in both, they are male. Karyotype XY. Phenotype, both of them, they have female external genitalia. Mullerian is the difference here. Mullerian structure will be absent in androgen insensitivity. Why? Because they have healthy. The Sertoli cells will produce MIS, Mullerian inhibiting substance. So in this case, the Mullerian structure will be inhibited and will be absent. No uterus, no fallopian. In the case of XY pure gonadal dysgenesis, the Sertoli cells will not be stimulated, and they have absent MIS, so no MIS, no Mullerian inhibiting substance. So if you let go, normally will develop internal female structure. There is nothing to inhibit, so they will have uterus, fallopian tube. Breast will be usually present in androgen insensitivity because the high testosterone will be converted to estrogen, and they will develop breast. In Swyer syndrome will be no breast because no testosterone. Menses will be absent in both. Vagina will be blind vagina in androgen insensitivity, and normal vagina in Swyer syndrome. Gonad, here is testes, here is streaks of gonad, undifferentiated. Both of them, they need to be removed because of risk of cancer. Testosterone will be high here in Swyer syndrome, will be low. Sexual hair will be little or absent here will be absent. So remember, XY pure gonadal dysgenesis will be female, internal and external. Structures will be present with amenorrhea, and no sexual hair, and testosterone will be low. Another case scenario, this is a 5-year-old boy with undescended testes. During the surgical correction, a uterus and a fallopian were found while pulling the testes. Karyotype is XY, normal size penis. What is the most likely cause? The key word here to know a case like that is a boy with undescended testes and went for operation, and you found Mullerian structures were found during surgery. And the karyotype is a boy is XY and normal size penis, so everything is a boy with just internal Mullerian structure were found accidentally or incidentally. The key word here, normal male with incidental finding of Mullerian structures. So this is a classic presentation of persistent Mullerian duct syndrome. It will be no MIS function. The MIS or Mullerian inhibiting substance is not functioning, and if the MIS is not functioning, what happened? The Mullerian structure will develop the uterus and fallopian, and they will have normal testosterone. Male's reproductive organs plus uterus and fallopian tubes, because of the MIS is not functioning, so the uterus and fallopian will develop. Normal chromosomal study is a 46XY boy with normal external male genitalia, undescended testes. This is a common presentation, or cryptorchidism. Also, they may present with inguinal hernia as well. And undescended testes, if it's left untreated, may develop cancer. So usually most of the time they discover the fallopian and uterus when they correct the undescended testes or the inguinal hernia, or both. This is another case. This is a 14-year-old female presented to your clinic because of her voice change, development of facial hair, enlargement of her clitoris, absence of the breast, and menses. Physical examination is significant for masculine appearance, male voice, male hair distribution, no breast, enlarged penis, pubic hair, bifid, dark scrotum. Ultrasound showed testes in the inguinal canal, no Mullerian structures, no uterus, no fallopian. Parents are confused about the gender of the child, and the karyotype is XY. What is the most likely cause? The key word in this case is a normal XY male raised as a female because of ambiguous external genitalia. In order to understand this case, we need to go through this slide again. Differentiation of external genitalia, you need testosterone, and the testosterone need to be converted to dihydrotestosterone in order to develop the female external genitalia. So this child has deficiency of 5-alpha reductase, and the testosterone does not develop to, or is not converted to dihydrotestosterone, so they have ambiguous external genitalia. If the testosterone is not working, external genitalia appears phenotypically female, and this is the cases of androgen insensitivity. When the 5-alpha reductase is not working, you will have just ambiguous external female genitalia, but the child is actually a male, is a boy. This is a classic presentation of 5-alpha reductase deficiency. It is autosomal recessive. That's why in the history we have to ask about consanguinity due to the defect in androgen action on external genitalia. This can cause ambiguity of the external genitalia, but the peripheral action of testosterone is normal. Clinical presentation: newborn with a small penis, bifid scrotum, urogenital sinus, and a blind vaginal pouch. Testes are in the inguinal canal. Most infants raised as female, and they change to the male at the time of puberty. Surprise. At puberty, they have virilization. All the virilization will occur, male hair distribution, enlargement of the penis and the scrotum, and the sperm formation. They will reach the final adult height. This table is to differentiate between common cases of disorders of sexual development. The first one is a newborn with XX, which is female, with a virilization of external genitalia. Ultrasound shows normal Mullerian structures, means uterus and fallopian, ovaries as well. The lab is 17, hydroxyprogesterone will be elevated. This is a classic presentation of a female with congenital adrenal hyperplasia. They know that the most common cause of ambiguous genitalia in females is congenital adrenal hyperplasia. For the boys, the most common cause of ambiguous genitalia is androgen insensitivity. So the presentation of androgen insensitivity syndrome, XY female phenotype, means external genitalia look like female and raised as female. During adolescence, they will develop breast, no menses, no sexual hair because of resistance to testosterone. They will have blind vaginal pouch because they do have MIS, which is Mullerian inhibiting substance, secreted from the Sertoli cells, and undescended testes. They will have elevated testosterone level, and the testosterone will be converted to estrogen, and that's why they will develop breast. The next one is XY female phenotype, Swyer syndrome. They are raised as female because they have mutation in SRY gene. They do not stimulate the Sertoli cells or the Leydig cells, so they will develop externally and internally as female, with no breast, no menses, no sexual hair. They do have vagina, uterus, and fallopian tubes, and streaks of gonads undifferentiated, and low testosterone level because the Leydig cells is not producing testosterone. So this is just actually internally, externally looks like female with no breast, no menses, no sexual hair, and is very easy to identify. So the difference here, the androgen insensitivity, they develop breast, they have blind vaginal pouch, and the Mullerian inhibiting substance is normal, so they do not develop female internal organs. The next one is XY female phenotype at birth, which is a 5-alpha reductase deficiency. They do not develop breast, no menses. They develop sexual hair and enlarging penis during adolescence. So after birth, they have ambiguous male genitalia, and they raised as females. Then when they go through adolescence, they develop sexual hair normally because they are boys. They have normal testosterone, but just they are missing the dihydrotestosterone for complete development of the external genitalia. They do not have any Mullerian structure, no uterus, no fallopian. Testes are in the inguinal canal. So they during adolescence they look like very boys, and at birth they have ambiguous genitalia. The next one is XY normal male phenotype, which is really boy, but with internal structure of female in addition to the male structure. So they present usually with inguinal hernia and undescended testes, and during surgery they will find incidentally uterus and fallopian beside the testes while they are doing the correction. Why? Because they are resistant, or they have abnormal function of MIS, Mullerian inhibiting substance, so the uterus and fallopian will develop, and they do have testes. So just simply removal of uterus and fallopian will solve the problem. 45X46XY gonadal dysgenesis is very rare. May present as Turner. They are at high risk of gonadoblastoma. Gonads must be removed. Turner syndrome, for sure, you will see it in your exam, and you will meet at least one patient in your career. More than 95% of adult women with Turner syndrome are short and infertile. So generally, any short woman present with a short stature, you must consider Turner syndrome in your differential. Their karyotype is 45X chromosome. The clinical presentation, short stature, ovarian failure, markedly elevated FSH. The most common cardiac abnormalities is bicuspid aortic valve. This is the most common heart defect. Also, they may present with coarctation of aorta, aortic dissection. That's why you have to have a follow-up with echo, and hypertension. Also, Turner syndrome may present with lymphedema at birth, webbed neck, nuchal folds, widespread nipples, shield chest, multiple pigmented nevi, low hairline, low sit ears, small mandible, mid-lung deformity, which is deformity, increasing deformity in the wrist and decreased range of motion, and usually presents with pain as well. Cubitus valgus, short metacarpal bones scoliosis. Hypothyroidism is very important to screen Turner's syndrome for hypothyroidism learning disabilities. Diagnosis of Turner syndrome is karyotype. Diagnosis confirmed by presence of 45X. If you find 45X, 46XY mosaic presentation, this is a high risk for gonadoblastoma. LH and FSH rise to menopausal level after age of 10 years. Management of Turner syndrome: growth hormone to improve final height. Estrogen replacement therapy is usually required. Estrogen is usually started at age 12 to 15 years after height optimized. Follow up the TSH every 1 to 2 years because of high risk of hypothyroidism. Echocardiogram must be repeated every 5 years because of aortic dissection. Renal ultrasound for renal anomalies. Klinefelter syndrome, this is the most common major sexual differentiation abnormalities. It is 47XXY karyotype, abnormalities of non-disjunction during meiosis. Clinical presentation: mild intellectual disability, small penis, testes are small and firm, very small and firm, less than 2 cm or 2 ml. Azoospermia, no sperms, gynecomastia, they are at high risk of male breast cancer. Decreased facial hair, but the pubic hair is normal. Diagnosis of Klinefelter syndrome: karyotype, elevated FSH and LH, low level of inhibin B, increase estradiol to testosterone ratio. Management: testosterone replacement after age 11, intramuscular or transdermal. Testosterone dose is 25 to 50 mg intramuscular every 3 to 4 weeks. Increase the dose by 50 mg every 6 to 9 months. The goal is 200 to 250 mg every 3 to 4 weeks. Surveillance for breast cancer is important. Gynecomastia is very common in adolescents and usually benign. So gynecomastia is a benign enlargement of male breast, usually bilateral, but sometimes is unilateral. And again, it is very common in adolescents and require reassurance. Presence of a rubbery or firm mass, usually you will find extending concentrically from the nipples. Gynecomastia should be differentiated from lipomastia, which is just fat, no breast tissue, which is characterized by fat deposition without glandular proliferation. Causes of gynecomastia: estrogen-androgen imbalance, pubertal like physiologic gynecomastia, which is common and require reassurance. Klinefelter syndrome: testicular tumor, ectopic production of HCG, chronic liver disease, hyperthyroidism, adrenal tumor, familial gynecomastia, and prolactinoma. Approach and consideration of a child presents with gynecomastia: asymptomatic and pubertal or physiologic gynecomastia do not require further testing, require just re-evaluation periodically. Red flags: if the breast size is big, more than 5 cm, a lump that is tender, or if recent onset progressive, or if is of unknown duration. Signs of malignancy, like for example hard or fixed lymph nodes or positive lymph node finding, any red flags like calcifications or any red flags of malignancy. Further investigation of abnormal underlying cause is considered. Treatment of gynecomastia: generally no treatment is required. Pubertal gynecomastia resolves spontaneously within several weeks to 3 years. Polycystic ovary disease can result from abnormal function of hypothalamic pituitary ovarian axis. Clinical presentation: menstrual dysfunction due to anovulation, hirsutism, infertility, obesity, metabolic syndrome, acanthosis nigricans, diabetes, hypertension, obstructive sleep apnea. Diagnosis: the FSH level usually are within normal range or low. The one will be high is the LH. The LH will be elevated, and the LH to FSH ratio is usually greater than 2 to 3. You will see elevated testosterone level in this case as well. Recommended test for a child presents with or suspected polycystic ovary disease: TSH-free thyroxine, serum prolactin level, serum HCG level, glucose level, insulin level, lipid panel, 17-hydroxyprogesterone to exclude late onset CAH or congenital adrenal hyperplasia. Karyotype usually excludes mosaic Turner as a cause of primary amenorrhea. Diagnosis: ovarian ultrasound, enlarged ovaries and cyst may or may not present. Very important. Management: diet and exercise are considered the first treatment of women with or girls with polycystic ovarian syndrome. Oral contraceptive to induce regular menses, metformin for insulin resistance. Diabetes mellitus. This is a very important section, and this is the final section in this presentation. Type 1 diabetes mellitus. Possible factors contributing to the development of type 1 diabetes mellitus: susceptibility, genetic factors, human leukocytic antigen molecules DR3 and DR4 carries the greatest risk for development of type 1 diabetes mellitus. A child or sibling of type 1 diabetes mellitus, the risk is 4 to 6%. Environmental factors: viral infection is the most important environmental factor for development of type 1 diabetes mellitus, for example, enterovirus or congenital rubella. Breastfeeding decreases or lower the risk of or for type 1 diabetes mellitus. Any of these factors or all of them, they contribute to development of antibodies, and these antibodies eventually will destroy the beta cells and deficiency of the insulin and development of type 1 diabetes mellitus. Clinical presentation of type 1 diabetes mellitus: hyperglycemia, glycosuria, polydipsia, polyuria, unexplained weight loss, non-specific malaise, ketoacidosis. Associated condition: hypothyroidism and celiac disease. Very important to remember that because it's very important for screening, periodic screening of type 1 diabetes for hypothyroidism, and a child with type 1 diabetes mellitus present with abdominal pain, screening for celiac is very important. Close to infant with possible diabetes mellitus or DKA is vomiting and polyuria, because when the child is vomiting, the urine should be less, not more. So vomiting and polyuria is a red flag. Persistent candida rash or diaper rash or oral thrush is also a clue for possible diabetes mellitus. Diagnosis of type 1 diabetes mellitus: fasting blood glucose level more than or equal 126 mg per deciliter, or 2-hour plasma glucose level more than or equal 200 mg per deciliter, or random plasma glucose more than or equal 200 mg per deciliter with symptoms of hyperglycemia. Hemoglobin A1C more than or equal 6.5 is also diagnostic of type 1 diabetes mellitus. Positive autoimmune markers: this is the key for type 1. Glutamic acid decarboxylase antibodies, insulin islet cell antibodies, and zinc transporter antibodies. Management of type 1 diabetes mellitus: there is no other option other than insulin therapy and injections of insulin daily. You have two types: basal insulin, long acting, like for example glargine or detemir, and preprandial or pre-meal insulin. And now what is used now is the rapid acting Lespro or Aspart. This is the most commonly two used, Lespro and Aspart. This is an example of a 10 years old 32 kilogram patient with new onset type 1 diabetes mellitus. How to calculate the insulin for this patient? The total daily dose of insulin, of subcutaneous insulin, is calculated as 0.5 to 1 unit per kilo per day. When should I use 0.5 in infants and young children to prevent hypoglycemia? I will use the higher end, like 1 or 0.8 or 0.9 to older children and adolescents, because they can feel simply the hypoglycemia and symptoms of hypoglycemia. So the dose here for this patient is 10 years old is 32 times 0.75. For example, if this is 12 years old, I can use also 0.8. So and then you will adjust the level of the long-acting insulin depending on the measurements. So initially you can do it this way: 32 times 0.75 equal 24 units per day. Then the long-acting insulin will be, or the basal insulin will be calculated as half of the total daily subcutaneous dose, which is half of the 24. So 24 divided by 2 equal 12 units. So this patient initially will require 12 units of long-acting insulin in form of Glargine, Lantus, or Detemir, Levemir. Then the other half will be corrected by the rapid insulin. So when you need to give the other half before meals, 3 to 4 times per day. So, but in this case, you need to calculate the coverage for carbohydrate and coverage for hyperglycemia or high blood sugar. So the coverage for carbohydrate is you will use a standard number 500 divided by the total insulin daily insulin dose, which is 500 by 24 divided by 24, the one we calculated in the beginning. So this will be equal 20 grams. So this patient will need 1 unit for each 20 gram of carb he or she will eat. Then if this patient is going for a meal of 80 gram of carb, this patient will need 4 units of rapid insulin in order to cover for this meal. Then also before the meal, they are measuring the level of the blood sugar. So you need to calculate their correction factor. So you will do 1800 divided by the total daily insulin, which is 1800 divided by 24, which is this number, 24 we calculated in the beginning. So it will be equal 75. So this patient will need 1 unit for each 75 milligram per deciliter of blood sugar above the target. How would you calculate the target? For example, this patient I will give a target of 120. The younger the patient, the higher the target. For example, in infants, I will make it more than 200 or 200 or a little bit more to prevent hypoglycemia. And the older the patient, you lower the target because the patients will feel the symptoms of hypoglycemia if they develop. So now this patient is going for a meal, and we want to calculate the bolus to be able to give this patient the appropriate amount of rapid insulin before the meal. So the blood sugar level is 270, and this patient is going to eat 80 grams of carb. So we know that now the insulin to carb ratio is 1 to 20. 1 unit of insulin required for 20 grams of carb. So this patient is going for 80, so he or she will require 4 units of rapid insulin in form of Lispro or Aspart. And the correction factor, the blood sugar of this patient is 270. So 270 above 270 minus the 120, which is the target. So this patient is having 150 milligram per deciliter above the target, above the 120. So this patient will require 2 units to correct for the hyperglycemia because the correction factor is 1 to 75. So 2 plus 4 is 6. So this patient will require a bolus of rapid insulin in form of Aspart or Lispro, 6 units before this meal. Insulin pump is another method for delivering insulin to children with type 1 diabetes. All the patients with insulin pump, they have to be well trained, and they started initially on the injection first, and the insulin pump will be later on when they are very, very familiar with the injection. Also, the difference is that insulin pump use only rapid insulin, no long-acting insulin in the insulin pump. So the basal insulin we calculated in the previous case, like the 12 units of Lantus, it will be entered in the machine as 12 units per day and will be divided over the 24 hours delivered to the body by the machine in form of rapid insulin, not long-acting insulin. The advantage of insulin pump can use a smaller, much smaller dose than you can use for injection. So for example, you can use quarter of unit or less than that through the insulin pump, but you cannot do that with the injection. The advantage also is less injections and pain per day, but still the patient has to measure the blood sugar to be able to calculate the bolus of rapid insulin to cover for the carbohydrate and the hyperglycemia, if any. The insulin pump will deliver the insulin through a catheter inserted under the skin by different method depending on the machine manufacturer, and the site should be changed every 3 days. The patient should be advised to change the site if they develop ketosis and they do not use the insulin pump until the ketosis or they feel better, using the injection until the ketosis is resolved and they feel well. Monitoring of patients with type 1 diabetes mellitus is with hemoglobin A1C. The target hemoglobin A1C is less than 7.5% in all pediatrics. Hemoglobin A1C equals 7% means that the average of blood sugar is 150 milligram per deciliter over the previous 3 months. Measurements of hemoglobin A1C reflects 3 months worth of control of blood sugar. Screening of type 1 diabetes mellitus should be 5 years after the diagnosis, and for type 2 at the time of the diagnosis. Screening for microalbuminuria and dilated eye exam. Careful neurological examination screen every 5 years after the diagnosis of type 1, and the TSH level every 1 to 2 years because of risk of hypothyroidism and at any time if the patient is showing any symptoms. This is a 9-year-old female with type 1 diabetes mellitus complaining of abdominal pain and weight loss. What is the best screening test? The best screening test is to screen for celiac disease with tissue transglutaminase antibodies and IgA antibodies. Diabetes ketoacidosis. Diabetes ketoacidosis is a severe insulin deficiency, causes metabolic acidosis and dehydration. Cerebral edema is the most common cause of death in type 1 diabetes mellitus. Precipitating factors that could lead to the onset of DKA or diabetic ketoacidosis infection, insulin omission, the patient is not taking especially the long-acting insulin, insulin pump failure like the kinked catheter, failure to match the insulin dosing to metabolic requirements during illness or stress. So the patient, when they are sick, they need to increase the dose of insulin. Diagnosis of diabetes ketoacidosis: blood sugar level more than 200, pH less than 7.3 and bicarb less than 15. Severity of the DKA: pH in mild cases the pH will be 7.21 to 7.3 and the bicarb between 11 and 15. Moderate, the pH will be between 7.11 to 7.2 and the bicarb will be between 6 and 10. Severe DKA, the pH is less than 7.1 and the bicarb is less than 5. Management of DKA: in the first hour, fluid resuscitation only without insulin, no insulin in the beginning. So in the first hour, for fluid resuscitation with normal saline 10 cc per kilo over 1 hour. In the second hour, we'll give insulin and rehydration fluid. Insulin will be 0.1 per kilo per hour, and the rehydration fluid is normal saline, no sugar, plus 40 mg of potassium. The can be divided to 20 mg of potassium phosphate and 20 mg of potassium acetate, and the rate will be the maintenance for each 24 hours normally plus 50 cc of deficit divided over 48 hours evenly. Rarely the fluid rate exceeds 1.5 to maximum 2 maintenance. When blood glucose level between 250 to 300, you need to change the IV fluid from normal saline to D5.5 normal saline with the same potassium and the same rate. You may change the potassium acetate to potassium chloride. Remember that the blood sugar will correct before the acidosis, so we need the insulin to correct the acidosis. So you need to continue the insulin until the acidosis is corrected. And when the DKA is resolved, you will know that if the pH is more than 7.3 and the bicarb is more than 15. And you will be able to discontinue the IV fluid if the patient tolerated PO intake. And before you discontinue the IV insulin, you need to give a dose of subcutaneous insulin before discontinuing the IV insulin. Very important to know about DKA. If the blood glucose concentration drop to less than 150, in this case you need to change the IV fluid. Instead of D5, you may go to dextrose 10% or even 12.5% can be used, because the goal here is to correct the acidosis with the insulin. Blood sugar will correct faster. IV insulin therapy should continue as long as the patient is acidotic. This is the main goal, is to correct the acidosis. Decrease IV insulin rate if persistent hypoglycemia despite the maximum dextrose administration. Management of DKA is always in the ICU, so this patient need to be with close monitoring, vital signs, mental status, neurological evaluation, serum glucose, electrolyte, serum phosphorus, blood urea, nitrogen, creatinine, pH, urine ketones, all should be measured at the time of presentation. Then hourly you need to measure the serum glucose and pH. And every 2 to 3 hours you need to measure the electrolytes and urine ketones. If the phosphate is administered, you need to monitor the serum calcium very closely. Cerebral edema is the most important complication to keep in mind when you are treating a child with DKA. Risk factors for developing cerebral edema is treatment with bicarb. Acidosis should be corrected with IV hydration and insulin, not bicarb. So do not use bicarb in cases of DKA. Over aggressive fluid replacement. That's why we started the bolus with 10 cc per kilo of normal saline over 1 hour, not 20 cc over 30 minutes, for example. So you should do the bolus slowly with 10 cc, not 20 cc. So in the first hour, just normal saline, 10 cc per kilo over 1 hour. Then too early introduction of insulin also is a risk factor for cerebral edema. That's why we started the IV insulin in the second hour after IV bolus hydration. The clinical presentation when you are treating a child with DKA and the child start vomiting after the vomiting already stopped, or start to complain of headache, abnormal drowsiness, altered mental status, sustained and inappropriate bradycardia, older child start to have enuresis, diastolic hypertension more than 90 millimeter of mercury. This is a red flag for developing diabetic cerebral edema during the treatment of DKA. The treatment of cerebral edema is mannitol to lower the intracranial pressure. Management of sick days in the patient with diabetes mellitus. The first thing to check the blood glucose every 3 to 4 hours until feeling well. Of course, you need to encourage the patient to drink a lot of liquids, and you may give anti-nausea or anti-vomiting medicine like Zofran to help the patient to take more liquids to stay hydrated. Give a correction factor with rapid acting insulin every 2 to 3 hours to correct the blood sugar level, even if the patient is not eating, but still you have to encourage the patient to drink a lot of liquids. Check the urine ketone concentration every 3 to 4 hours. You may increase or even double the correction factor. So if the patient requiring, for example, correction of high blood sugar 2 units, you may give even 4 units because of increased insulin resistance when the patients with diabetes are sick. Insulin pump. If the patient is using insulin pump, you need to change the site immediately. Change the site of insulin pump because it could be because of insulin pump failure to deliver the subcutaneous insulin. Correction, you need to correct the acidosis with injection until the ketones are negative. Then you resume the insulin pump after changing the site. Encourage fluid intake. If glucose level is more than 200, sugar-free fluid should be given. If glucose level is less than 200, sugar-containing fluid should be included. Anti-nausea medicine can be used and actually advised if the patient having nausea. Factors requiring immediate intervention and going to the hospital is persistent vomiting, moderate to large ketone levels, inappropriate rapid breathing, altered mental status, inability to perform sick days role. Management of hypoglycemia in the patients with diabetes mellitus. Remember, general pediatricians, they should be familiar with treatment of all kinds of cases of emergencies because they may be the first one will face this problem. So if the patient is conscious, you need to give 15 grams of carbohydrate in form of juice or glucose tablets or gel. If the blood sugar is more than 40 and less than 70. If the blood sugar is less than 4, you double the amount and give 30 grams of carb to correct the hypoglycemia. Then you need to recheck again in 15 minutes. And you repeat the process again if needed if the blood sugar is still less than 70 milligram per deciliter. Once the blood sugar is corrected and become more than 70 milligram per deciliter, you give the crackers or the carbohydrate with fat, for example peanut butter or cheese, to last longer. If the patient is unconscious or not able to drink, you need to give glucagon. 1 milligram intramuscular. If the patient weight is less than 20 kilo, you give just half milligram. Do not give glucagon for patients with ketotic hypoglycemia or glycogen storage disease. IV fluid or IV dextrose is preferred over glucagon if it's already in the hospital. So if the patient is having already IV access, do not give glucagon. IV dextrose will be preferred. This is the last break we'll take. This is 11 years old female with 3 weeks history of nausea, headache, increased thirst, history of recurrent yeast infections. Urine test is negative except for glucose, is positive for glucose, but the urine do not have ketones. Blood sugar level is 220 milligram per deciliter. Her triglyceride is 330 milligram per deciliter. Her hemoglobin A1C is 8%. Her BMI is more than 98%, so she's obese. And she has positive acanthosis nigricans around her neck. Of the following, the best initial treatment to give insulin for this patient, or metformin, or rosiglitazone. So this is a classic presentation of type 2 diabetes mellitus with random blood sugar less than 250 and hemoglobin A1C less than 9, and also the patient showing the obesity and the positive acanthosis nigricans. So the best treatment for type 2 diabetes mellitus in this case is metformin. Also the patient does not have a ketone in urine, so there is no ketoacidosis. This is a child with a high BMI. The mom presented to the office complaining that the neck keep getting darker and darker, and she tried many methods to clean the neck, but nothing was working. Diagnosis of type 2 diabetes mellitus, positive family history. You will find with type 2 there is a positive family history more than the cases of type 1. Signs of insulin resistance, like for example acanthosis nigricans, if random blood sugar is 200 or greater in association with polyuria, polydipsia, or unexplained weight loss. Also, if the fasting blood sugar is 126 milligram per deciliter or greater, or 2-hour plasma glucose level 200 milligram per deciliter or greater during the oral glucose tolerance test, or hemoglobin A1C more than 6.5%. Indication for oral glucose tolerance test is very important to know that if you do fasting blood sugar and the fasting blood sugar is 100 to 125, in this case the second step is to do oral glucose tolerance test. Also is indicated if you suspect the type 2 diabetes mellitus because of acanthosis nigricans, family history of diabetes mellitus, polycystic ovary disease, or high BMI. Laboratory results that usually suggest type 2: elevated fasting C-peptide level, elevated fasting insulin, and absence of autoimmune markers. This is classic for type 2. So elevated C-peptide because the pancreas working so hard because of high insulin resistance, elevated fasting insulin, and absence of autoimmune markers. Autoimmune markers is classic for type 1, not type 2. When you need to screen for type 2 diabetes mellitus, this is ADA recommendation: BMI more than 85% and other 2 risk factors like family history of type 2 diabetes mellitus or second degree relative with type 2 diabetes mellitus, race and ethnicity, African American and Hispanic, signs of insulin resistance like hypertension, acanthosis nigricans, polycystic ovary disease. Start screening at age of 10 years of age or with onset of puberty. Repeat the fasting blood glucose every 3 years if it's still normal. Management of type 2 diabetes mellitus is very important. Diabetes education and lifestyle change like diet and exercise and weight control. Weight control is a key for treatment of type to diabetes mellitus, because the more the weight, the more the insulin resistant, and the more the patient will lose weight and lose fat, especially the visceral fat, this will increase the insulin sensitivity and decrease the blood sugar afterward. Pharmacological therapies, the best or the drug of choice is metformin. Metformin for children, what is approved for children is metformin, is the drug of choice. Insulin, if the patient presents with ketosis or DKA, you need to use insulin. If the hemoglobin A1C more than 9%, or if the random blood glucose is 250 milligram per deciliter or more. Lipid lowering agents and blood pressure medication to achieve cardioprotection if necessary. Obesity is a major problem facing the children nowadays, and BMI should be calculated in each well visit in children 2 years and older. BMI is defined as kilograms of body weight per height in square meter. Overweight means the BMI is between 85 to 94 percentile. Obesity, if is at or above 95 percentile, is considered obesity. Causes: idiopathic or familial obesity. This is the most common cause of childhood obesity. Hormonal hypothyroidism, Cushing syndrome. In this case, the child will be short. Polycystic ovary syndrome. Other causes of obesity: Down syndrome, and the most important manifestation of Down syndrome is hypotonia. Prader-Willi syndrome, hypotonia, hypogonadism, hyperphagia, small hands and feet. Albright hereditary osteodystrophy, short stature and skeletal defect. Fragile X intellectual disability, large testes and large ears. Genetics, for example, congenital leptin deficiency. Definition of pediatric metabolic syndrome is very important. Central obesity and increased waist circumference, plus at least 2 of the following 4 clinical risk factors: hypertension, low HDL less than 40, high triglyceride, fasting blood glucose level more than or equal 100 milligram per deciliter, or previously diagnosed with type 2 diabetes mellitus. You need to memorize the pediatric metabolic syndrome criteria: central obesity with increased waist circumference, plus at least 2 of the following 4 clinical risk factors: hypertension, low HDL, high triglyceride, fasting blood glucose more than or equal 100 milligram per deciliter, or previously diagnosed with type 2 diabetes mellitus. Remember, acanthosis nigricans is not one of these criteria. Obesity-related conditions, depression and isolation is the most common complication of obesity in children and adolescents. So during encounter in any child with obesity, ask about any bullying in school. Fatty liver infiltration, NASH, which is up to 25 to 83% of the cases of obesity. Cholelithiasis. Patients with obesity, they tend to have more severe asthma than normal children. Acanthosis nigricans is associated with obesity as well because of insulin resistance. You need to ask the patient with obesity about sleep pattern, if there is any obstructive sleep apnea, because this can cause metabolic alkalosis, respiratory acidosis, hypoventilation, pulmonary hypertension, right-sided heart failure. Obesity hypoventilation syndrome, hypertension is common with obesity, dyslipidemia, and also this can cause the fatty liver as well. Obesity related conditions, nocturnal enuresis, because of obstructive sleep apnea. So if the patient has a large adenoid and tonsils, if you remove that and you correct the obstructive sleep apnea, you may correct the nocturnal enuresis. Why nocturnal enuresis? Because of excess secretion of atrial natriuretic peptides. Skeletal, they may develop slipped scapular femoral epiphysis, is commonly associated with obesity. Joint pain, Blount disease, commonly associated with obesity. Osteoporosis. Treatment of obesity is very complicated and requires a multidisciplinary approach, and it should be family oriented, or family. All the family, they should participate in the treatment of the obesity. Weight reduction, diet and exercise, all the family must share this part, diet and exercise. Management of obesity related conditions, for example obstructive sleep apnea, is very important to correct. Treatment of the cause if applicable.
Having trouble or trying to pass the pediatric board exam? We have the definitive solution for you, presenting the Last Minute Review Series, a powerful tool for achieving success in pediatric board exams. crafted by Dr. Osama Naga, a board-certified pediatrician by American Board of Pediatrics and the editor of the Pediatric Board Study Guide, a last-minute review. Dr. Naga breaks down the most critical subjects in this series. The Pediatric Last Minute Review webpage offers a thorough and rigorous set of pediatric board review sessions that are in line with the study guide. The lectures will cover the most important topics for each condition that a pediatrician must know for pediatric board exams, as well as real-life clinical encounters. The inclusion of a clinical case scenario, accompanied by multiple-choice questions, followed by the most probable answer and a comprehensive description of the issue, will ensure test readiness for each student. You will be able to download the lecture's PDF files to make your studies easier, to take notes and be accessible on the go and offline. Based on the membership plan you choose, you will have unlimited access to the lectures for either 1 month, 3 months, 6 months, or 1 year. By viewing these videos, you will increase your chances of passing the board exam and gain substantial advantages from the acquired knowledge. Additionally, by studying the material and completing the AAP prep questions from the previous 3 years, you will greatly increase your likelihood of passing the board and will acquire a wealth of knowledge. Click on the link provided below to visit lastminutepediatric.com and subscribe immediately. Be sure to take advantage of our free video samples on our YouTube channel, Pediatric Board Last Minute Review. Good luck with your exams.
This lecture is only for educational purpose, not intended for direct care for any specific patient. Please consult your physician or the physician of your child for the correct diagnosis and the proper treatment. Thank you.